and it is my pleasure to serve as your chairperson for today. I look forward to an engaging, inspiring, and highly productive day together. Utilitarian Conference Gathering, or UCG, is a leading global platform dedicated to organizing high-quality professional meetings, conferences, workshops, and symposiums. With a strong focus on medical, clinical, healthcare, life science, and pharmaceutical fields. UCG effectively bridges the gap between academia, industry, through innovation, collaboration, and excellence. With a global reach, 24/7 support, and highly committed organizing team, UCG ensures that every event is impactful, well-structured, and tailored to meet the evolving needs of its participants. On behalf of UCG, I extend my heartfelt gratitude to our organizing committee, distinguished speakers, and all participants who have contributed to making this gathering a success. Together, we are driving progress and shaping the future of healthcare. So we have session timings today. Our keynote speakers will be 20 minutes, oral presentations for 20 minutes, as well as poster presentation for 15 minutes. Ladies and gentlemen, for our first speaker, Mrs. Gianna Manculio, Nurse Supervisor Maternity, joining us from the United Arab Emirates. She will present on strengthening patient safety culture through ethics integrated CUSP leadership. Kindly join me in welcoming her online. Thank you, Ms. Gianna. Ms. Gianna, when you are ready, you may join and start your presentation.
Good morning. Thank you so much for the opportunity. Just give me some moment. Good morning to all. Thank you so much for the opportunity to talk about ethics integrated cost leadership as a strategy to strengthen patient safety culture in nursing practice. Today I'm going to talk about ethics, and I will take you through cost leadership and how this is important for patient safety as a strategy. Let me start with a simple question. Have you ever noticed something unsafe but choose to stay silent? Not because you didn't care, but because it didn't feel safe to speak. Today, I'm not just presenting a project, I'm sharing something we all experience, but rarely we talk about it. The gap between knowing and speaking up, and how, as a nurse leaders, we can close that gap. I will walk you through a journey. First, let's understand where we are now, then where we need to be, and finally, what's stopping us. And the most important thing, how we can change it together.
Excuse me, Ms. Jihana, could you kindly share your slides?
Excuse me?
Could you kindly share your slides?
Yeah, just give me a moment. I will just go from the beginning. One second. Where is the app? Are you able to see me? Excuse me?
No, not yet. We're not able to see your slides yet.
Now it's fine?
Yes, thank you very much. We can see. You may proceed.
So I can start from the beginning, yeah?
Yes, please go.
I want to move the screen there. Sorry, just give me a moment. Now we can start. Are you able to
Yes,
hear me,
be
Sibel?
able to see your slides as well. Thank you. Proceed.
Thank you so much. Thank you. Good morning, everyone. Today I'm going to talk about ethics, and I will take you through CASP leadership and how this is important for patient safety as a strategy. Let me start with a simple question. Have you ever noticed something unsafe but choose to stay silent? Not because you didn't care, but because it didn't feel safe to speak. Today, I'm not just presenting a project. I'm sharing something we all experience but rarely talk about, the gap between knowing and speaking up. And how, as nurse leader, we can close that gap. I will walk you through a journey. First, let's understand the current status, where we are now, then where we need to be, and finally, what's stopping us. And the most important thing, how we can change it together. It is not just theory, it is real practice. And the most important is the real impact and the people who are contributing. Let's start with the current state and to take you into a real shift. And let me give you an example. When a nurse noticed early signs of deterioration, how do you think she reacted? She hesitates and she might be thinking, maybe this is nothing, maybe she will be blamed, maybe she shouldn't even question. That delay can cost minutes, and in healthcare, all we know, minutes matters. We already have the protocols in place, policies, comprehensive unit safety-based program, reporting systems. But systems don't fail. The silence does. Now imagine a different shift. When a nurse says, I'm concerned, and the response is, thank you for speaking up with no fear, no hierarchy, no blame. Just one shared goal, save patient care. That's the culture we are building. The problem is not a lack of system. The problem is culture, fear, hierarchy, lack of psychological safety. And the result is a delay in escalation and under-reporting incidents. And all of this will increase patient risk. So the question is not, do we have systems? The question is, do people feel safe to use them? We set the objectives and we use smart one with a key goal to increase reporting with about 30% in 6 months. This doesn't mean these things got worse. It means staff felt safer to speak up because every report is not a failure. It is an opportunity to prevent harm and protect the next patient. And when ethical leadership support program like CASP, we create a culture where staff report confidently without fear. When staff feels safe to speak up, risks are identified early, escalation is faster, and harm is prevented. This means fewer adverse events and better patient outcome. A near miss reported today protects the next patient. That's the true impact of patient safety. We don't speak up, complication happened. And as a result, the length of stay increases and cost rise. But when we act early, when we speak up, we prevent harm, we reduce the cost, and we protect resources because at the end of the day, safety is not expensive. Silence creates delay, but speaking up creates clarity. When teams communicate openly, decisions become faster and care becomes smoother, work becomes easier. It's not about working harder, it's about working safer. Let's talk about something real, moral distress. When nurses know what's right, but feel unable to act, this leads to burnout, frustration, and disengagement. But when all of us, we create safe environment, nurses feel heard, they feel valued, and they feel confident. And that changed everything. If we don't change, silence continues, errors remain hidden, and risk increases. But if we change, we create a culture of trust, a culture of safety, and a culture of courage. Our solution is simple. Ethics integrated with CASP are not just tools, but behavior. We focus on psychological safety, a speak-up culture, and just culture principles. Because safety, it's not only clinical, it's human. So what do you think will change? We'll see more reporting, less harm, better teamwork, and stronger trust. And most importantly, a safer patient journey. This is not one-time training, it's daily practice, consistency. We'll train the leaders, we integrate ethics into CASP rounds, we encourage speaking up and provide regular feedback. Because culture is not taught once, it is built every day. We measure what matters, not just numbers, but behavior. Are people reporting? What do you think? Are they speaking up? Are they feeling safe? Because culture must be visible. I want to remind you, patient safety, it's not about protocols, checklists, or systems. It is about people.
Oh, it's this conference I have to listen to. I'll just put it away.
As nurses, we are the front line of care. And every day, we face moments where ethics guides our decision. CASP gives us structure, but ethics gives us courage to speak up. Because knowing what is right, it's not enough. We must feel safe to act on it, and when nurses feel safe, supported, and heard, we don't improve the outcomes, we protect lives. If you remember only one thing from today, from my presentation, safety is not only systems, it is culture. And culture is created by leadership, and every time someone speaks up, a life may be saved. Let me end with this. The safest hospitals are not the ones without errors, but the ones where people are not afraid to speak. Thank you.
Thank you very much, Ms. Gianna, or how do I pronounce your name?
Janina, is it right?
Janina, thank you so much. I think the most important thing for me, the takeaway here was safety is a culture, and we need to speak up. That can save a life. So that is so important for us in the healthcare. So may I ask to the audience here, do you have any questions for our esteemed speaker? Please go ahead. Anyone? Okay.
If you allow me,
Yes, please.
we often mix culture, free blame or no blame culture with accountability. And people usually mix fear with being accountable. As a healthcare organization and leadership, how do you differentiate between a real accountability and fear of reporting or self-reporting fear?
This is a good question. Thank you so much. You are really right to talk about it. We face challenges always because the biggest barrier was staff are hesitating to be blamed and the hierarchy. And we implement the open door policy. And based on our past experience, we address this consistently. The staff should feel they are supported by leadership. And over time, that trust grow. What was the most important thing when we create this culture about the speak up and engagement of the leadership? That was the most important for us. So we just encourage daily safety question. We create these safety hurdles and we encourage all the multidisciplinary team to speak up.
Thank you very much. If there is no further questions, we would like to say thank you very much for your presentation, your insightful presentation, and your valuable contribution to patient safety and leadership, and taking the time to actually prepare this presentation. Really, thank you very much. Now, for the next speaker, it is my pleasure to introduce Dr. Fouzia, specializing in pediatric dentistry, who joins us also from the UAE, and she will be presenting on managing the pediatric patient with amelogenesis imperfecta. Kindly join me in welcoming Dr. Fouzia. Thank you.
Hello, everyone. Thank you for having me. Can you hear me?
Yes, you are audible.
Okay, that's good. I'm going to just share my... Just a moment. Okay, can you see my...
Yes, we can see the screen.
Okay, that's good. So, hello, everyone. My name is Fouzia Shafi, and I'm going to talk about managing the pediatric patient with amelogenesis imperfecta AI. But before I start actually with the topic, I'll give you just a small introduction about myself. So I'm born and raised in Dubai, and this is a picture of Dubai. So this is my favorite city, of course, because it's home. I studied at Ajma University. I finished my BBS for 5 years. And after that, I pursued my master in clinical pediatric dentistry at the University of Manchester in the United Kingdom. And this is specifically where I get my training at the University Dental Hospital of Manchester for 3 years in pediatric dentistry. So to start with, I'm going to just give a definition about the amelogenesis imperfecta. So,
excuse me, Dr. Could you kindly open your video?
I'm not able actually because I'm the clinic. I'm very sorry.
Okay, understood.
Yeah. So the definition of the amelogenesis imperfecta is the hereditary enamel defect which affect the structure and clinical appearance of the enamel, and it affects both dentition in a more or less equal manner, and it can be associated with morphologic or biochemical changes elsewhere in the body. So we have different types of amelogenesis imperfecta. We have hypoplastic type, in which the quantity of the enamel will be affected, as we can see in the picture. So we can have different appearance of the teeth, like grooves, fissures, pitting. So the quality of the enamel is not affected. The remaining tooth structure has a good quality, like a healthy tooth, but the quantity is affected. So the teeth might have that groove and pitting and fissures, or they might actually appear smaller compared to normal teeth. The other type would be hypomature or hypomineralized type of amelogenesis imperfecta. As we can see in this picture, in this type of AI, the quantity is not affected, but it's the quality of the enamel. And usually they are hypomineralized enamel. And as a result, we can see that there will be like a post-eruptive breakdown, chipping of the enamel, which can cause this discoloration, as we can see in the picture. And this is because of the lower quality and poor quality of the enamel. Hypocalcified also is considered another type of hypomineralized amelogenesis imperfecta, but it's more severe compared to the hypomature type. And as we can see clearly in this picture, so usually in this type, the quality is more like severely affected compared to the hypomature, which can lead to a very soft enamel structure that can be worn away very easily. And as a result, actually, the tooth will lose the translucency. It can appear yellow or light orange, and it can be very sensitive, which can make also maintaining the oral hygiene of the teeth very difficult for the patient. The fourth type would be a combination of hypomaturation and hypoplasia, and it's associated with taurodontism. So this type of AI, it's both affecting the quality and the quantity of the enamel. And as we can see in the panoramic, the OPG radiograph, we can see that it's associated with taurodontism, in which actually we have also apical migration of bifurcation apically, and the pulp chamber will be affected as well. There's one syndrome that can be actually associated with amelogenesis imperfecta, and that's called trichodental osseous syndrome. Usually in this syndrome, we have like severe attrition of the teeth. Again, we have that taurodontism, which can see in the OPG X-ray or radiograph. And in the skull, the X-ray of the skull will appear like a sclerotic bone. And the key feature also the hair in the children that can be very thin, as we can see in the picture. Now, when it comes to diagnosis of the amelogenesis imperfecta, if we have any patient or any child with amelogenesis imperfecta, it's very important actually to distinguish between the AI, amelogenesis imperfecta, and other type of teeth defect that might resemble amelogenesis imperfecta. So it's very important to take a very good history of the patient to understand whether is it AI or it's other type of teeth defect. For instance, we have dental fluorosis, which can be very they look like AI, especially the hypomature type, as we can see in the picture. But when we see a patient, then taking a very detailed history from the patients and the parents would be very, very beneficial in guiding us to have a proper diagnosis. For instance, we can ask if this is running in the family, if another sibling or another member of the family have the same condition. If the answer is yes and positive, that actually suggests that it's a hereditary, it's a genetic one. So mostly it's the AI, it's not dental fluorosis. We can ask also whether it was affecting both the primary and permanent dentition. If the patient is in a permanent dentition or mixed dentition, we can ask if when she or he had the primary teeth, was it the same? Because we know that AI will affect both dentition. And mostly with AI, it's more generalized, whereas in dental fluorosis, usually it affects the tooth that was developing at the time of having the excess amount of fluoride. Another question, a key question that we can ask, that where was the place where the child was born and raised? Because we know that there are certain places or certain countries that they have excess fluoride in their water naturally, and usually drinking that water during the childhood can affect actually the developing dentition, and that cause dental fluorosis. So those are the things that we need to consider, asking detailed history, plus also a radiograph can help us a lot of time in making the differential diagnosis. Another condition that might resemble also AI and could be mistaken by AI is a tetracycline staining. Again, getting a very detailed history, asking about if other family members affected by AI would help us actually to establish the proper diagnosis. In tetracycline staining, usually the child actually was exposed to a tetracycline antibiotic during the childhood, which usually we don't prescribe it for children because it can cause that discoloration. Usually the discoloration is like band type discoloration. And again, it affects the teeth that was developing at the time of taking that antibiotic. So getting the history, asking questions, and doing the clinical examination, in addition to radiographic examination, would be very helpful in establishing the proper diagnosis. The other differential diagnosis that we have to consider is trauma. So sometimes a trauma to primary teeth can affect actually the development of permanent teeth underneath. So when the permanent tooth erupts, it can erupt actually having some kind of malformation or some kind of abnormality in the color, which might actually be mistaken by with AI. So, but usually with trauma that affects a single tooth, one or two teeth, it won't be generalized like in case of AI. MIH or molar incisor hypomineralization, again, might resemble, but again, with MIH, we know that it can affect only the permanent first molars, one or all the four permanent molars, in addition sometimes to central incisors. So again, it's not generalized, and it's specific to those teeth only. And we have chronological enamel hypoplasia. Again, it's as a result of some kind of nutritional deficiency or trauma. And again, it's not generalized like AI. So again, taking history, doing a proper clinical examination would help us to know whether the case is AI or other kind of enamel or teeth defect. So I would like to talk about a case in which I had in the clinic. So this is a 9-year-old, 8-year-old child, a girl that came to the clinic, and she was suffering from amelogenesis imperfecta. And it was a hypomineralized, specifically hypomature type of AI. We can see that mostly the central incisors, she has like a breakdown of the enamel because it's affecting the quality of the enamel. So she had that breakdown. Her first permanent molars is somehow affected, but mostly her main concern and main complaint was about the central incisor. She had two concerns, and she had two complaints when she came to us. The first was severe sensitivity. And the other one was the aesthetic, and especially because she was a girl, so she was very concerned about the aesthetic and how she appears in front of her classmates and friends in the school and society. So those are the two main concerns that she had. So we did actually all the history taking and the clinical examination and the radiographic examination, the OPG, to establish the proper diagnosis. So that was her OPG actually, which shows that somehow the quality of the enamel in AI is affected, usually in the hypomature because the quality is affected, so the contrast between the enamel and dentine would be less compared to the normal tooth. Our treatment for this patient, of course, started with prevention. This is the most important thing. With all the children, we need to start with prevention, but specifically children with enamel defect like AI, we need to consider prevention because it's a key point. Now she was suffering from sensitivity, so it was very important that we manage that. And also it was very important because the quality of the enamel is affected. We want to make sure that she's not susceptible to develop decay or caries in her teeth. So prescribing her actually Durafat, high concentrated fluoride, according to the age, of course, that would be beneficial. Prescribing tooth mousse like CPP, ACP, casein, phosphopeptide, amorphous calcium phosphate also would help a lot with the sensitivity and strengthening the enamel because that mousse, the CPP, ACP, will deliver the calcium and phosphate, so it will rebuild the hydroxyapatite. It will strengthen the tooth, and some form of those tooth mousse actually they have fluoride sometimes, which can also help in prevention. We also tried to apply fissure sealant on her first permanent molars to protect it from decay, and also advise to use the tooth mousse at home. The other thing that we would actually recommend in this case, because they have sensitivity, is washing and brushing their teeth and washing with warm water and instead of cold one, because they have that severe sensitivity. The second phase was actually to address her main complaint, which was actually the aesthetic. So in this case, the two central incisors, she had like some kind of breakdown of post-eruptive breakdown of the enamel that appeared in a form of brown spots on her teeth. So our treatment was a direct composite veneer. Now, she's very young, so the aim here for dentist or pediatric dentist is just to be as conservative as possible because she's young, the teeth are young and very immature, so we want to preserve the tooth structure as much as possible and delay any kind of aggressive treatment till she becomes an adult 18-year-old. Then we can go for more a definitive restorative treatment, like, for example, crown or porcelain veneer. But for now, something very conservative, less aggressive, without touching the tooth structure, would be the main goal, and at the same time to manage the aesthetic and the sensitivity. So this is what we did. And this is the picture before and after. So our treatment was restorative treatment, direct composite veneer, and of course, referring the patient to a restorative department when she's older, when she's 18 and above, she can go for porcelain veneer, which is more aggressive and it actually requires some kind of tooth preparation. But we're not going to do it now because the tooth is immature and young. So there is and with a large pulp chamber, so there is if we do any preparation, that's not ideal at this age because there is a chance of exposure devitalizing the tooth. Of course, multidisciplinary management is the key here as well. As we saw in the picture, she was suffering from also some kind of malocclusion, like class 2 malocclusion with increased overjet. So she had to be referred to an orthodontic department for orthodontic management. So also that part should be considered by pediatric dentists. So yeah, it's a multidisciplinary management and is a kind of very conservative restorative treatment at this time, but then more definitive restoration when she's older. Now let's have a look, what does the literature say about treating a pediatric patient with AI? So usually the literature, they suggest composite veneer to manage cases like AI in children and adolescents and to improve the aesthetic. And the main goal is to improve the aesthetic, reduce the sensitivity, and reduce the incisal wear, and also restore the function. And this is what we did in our case, actually. Now, if you want to compare the direct to indirect composite veneer, I would say that both can be an option in treating a pediatric patient. However, our choice was a direct one, and the reason was that with the direct one, you have more flexibility for adjusting the composite because the patient is very young. There is a chance for the tooth to erupt more. So with the indirect composite veneer, although it gives us more strength and higher aesthetic and everything, but again, you need to add a layer of composite when there's more eruption of the tooth at the cervical area near the gingiva. So with a direct one, there is a chance for us to add that layer when the tooth erupts more because that cervical area will be exposed. Plus that it's quicker compared to indirect one. It's quicker, it's fast, and it's more cost effective. So sometimes also we need to consider other factors like the patient's and the parents' preference, their socioeconomic status, their time, whether they're able to come back or they want to finish everything in one visit. So all these factors can actually affect our decision whether we go with direct one or indirect. But usually direct one at this age, when the tooth is still erupting, might be a better option than indirect one. Now, there are so many challenges that a dentist can face when they are treating a child or a patient with amelogenesis imperfecta, mainly the aesthetic. It can affect the aesthetic. So this is one thing that we need to consider. And usually they come with a complaint of aesthetic and they want to improve it. The other challenge that we might face as a dentist is a bonding, especially not with the hypoplastic type of amelogenesis imperfecta, because with the hypoplastic, we have a problem with the quantity of enamel. It's not about the quality. But with the hypomineralized type, whether it's hypomature or hypocalcified, the quality is affected. So that might actually compromise the bonding if you want to do a composite restoration. Usually in literature, there is a suggestion that we can use a sodium hypochlorite 5% actually before the etching process to improve the bonding effect. And the reason behind it is that with the hypomineralized type of AI in which the quality is affected, usually we have excess amount of protein in the enamel. And what sodium hypochlorite does is that it deproteinizes the enamel. It removes the excess of protein, and that would help with bonding. I myself, I didn't try it, but I know that it's there in the literature, so it was worth mentioning. The other challenges for dentists would be the sensitivity, as we said, especially with post-eruptive breakdown, with the hypocalcified, especially type of AI, and anxiety. Why? Because the child with AI, when they come actually to you in the clinic, usually they're anxious. Usually they're suffering high sensitivity, especially with the hypomineralized type if they have breakdown. So they already anxious about opening their mouth and having the mirror or air or water inside their mouth. And that actually can be a challenge for a dentist when they are treating children or adolescents with AI. But there are ways actually to overcome that sensitivity and anxiety. So when we want to treat or restore teeth with AI in children, usually we have a combination of methods that we can use to reduce that sensitivity while we're treating the teeth and reduce the anxiety as well. So inhalation sedation using nitrous oxide would be an ideal for children with AI, because we know that nitrous oxide or inhalation sedation is both anxiolytic and analgesic at the same time. So it would reduce the stress and anxiety. Using local anesthesia would be very, very helpful, because that would give us the freedom and that comfort to treat the tooth without having sensitivity and pain. And of course, the ideal one would be articaine in children always, because it's ideal for children compared to other type of LA. Using rubber dam also would be very, very helpful, because that would isolate the other teeth. So while we are working on that specific tooth, the other teeth would be covered with the rubber dam, so they won't be exposed actually to air or water, which can actually cause sensitivity during the treatment. And of course, suggesting sensitive relieving toothpaste like Sensodyne would be also very helpful. Another challenge would be loss of vertical dimension, especially with hypocalcified, in which we have a rapid enamel wear, because the quality of enamel is very poor. So there is a chance of loss of vertical dimension. Using a preformed metal crown, stainless steel crown, would be very, very ideal in children to preserve the remaining tooth structure and also to preserve the vertical dimension of occlusion. I found this one very interesting from a study by Craig at 2013, that what was the children's view of other children with enamel defect? Because when we're treating pediatric patients with enamel defect, whether it's AI or any other type of enamel defect, it's very important for us as a dentist or pediatric dentist to consider the psychological aspect of a child. They're very sensitive. They can be affected by other people's opinion. And when they have this type of enamel defect that's affecting the appearance and aesthetic of their teeth, usually they can get bullied easily. They can hear, unpleasant things from their classmates and friends and other people. So in this study, actually, in this article, it was mentioned that children's judgment relating to this photograph, specific this photograph of a child with severe dental defect, included that this person or this child has no personal hygiene. This is what the other children actually thought about this child. Has eaten too much syrup or candy, or is lazy. So this is how other children will view a child with enamel defect, because they don't understand that this is a defect and it can be genetic and it's out of their hand. And we can understand that how it can have a negative impact psychologically on that child. So imagine that the child will come to you not having only pain and sensitivity and this abnormality in their teeth, but they are also psychologically affected. So it's very, very important that when we approach them or approach their family, we need to be very understanding. We need to be very insightful about it, and we need to show empathy, because that would help a lot actually for a child and their family to feel comfortable to start the treatment. Another example of psychological impact, like in a study in 2014, again, of children with AI, it shows that 50% reported being teased about their teeth. So this is again confirms that how it can affect them psychologically. Now, conclusion is that when we have any pediatric patient or any patient with AI and enamel defect, the most important aspect is usually to manage the sensitivity, manage the aesthetic, improve actually the function of the teeth, and the psychological well-being of a child or a patient also is a very important factor that we need to consider in our treatment and our conversation with the parents, with the child, and in our treatment. It's very important to have a very empathetic approach when we are talking with them, when we are dealing with this condition, because that's something that we should not only see the teeth, we should see actually the child or the patient as a whole, as a human being. And of course, protecting the vulnerable dentition. So patient with AI, with enamel defect, we need actually to make sure that we are protecting the remaining tooth structure so they can have it till they become an adult, when the dentist can have more freedom at that time to apply more definitive restoration or restorative treatment. And those are the references for my presentation. Thank you so much.
Thank you very much, Doctor. This was really something different. I think when you started speaking about AI, I was a bit confused because artificial intelligence. However, I do have, if nobody else has a question, I actually have 2 questions that I would like to ask. Could you kindly explain how does the approach from a pediatric dentist differs from a general dentist, the approach to treating AI in these patients?
Well, the difference between a pediatric dentist and a general dentist in treating children with AI would be maybe that the behavior management, this is something that maybe a pediatric dentist would be more expert in applying a behavior management suitable to that child. Because every children, they have their own specific character and personality, and so they need specific approach. Using actually a pharmacological behavior management by pediatric dentists would be also very helpful, like inhalation sedation or treating the patient under general anesthesia or under inhalation sedation like nitrous oxide. Sometimes IV sedation, for example, using propofol if they are a teenager. So those are the aid of pharmacological behavior management that a pediatric dentist can use compared to general dentists, which would be very, very helpful in patient with AI, because as I mentioned in my presentation, is that the patient will come to you anxious, having sensitivity. Probably they went through other phase of treatment with other dentists, with general dentists before, and because of the severe sensitivity, they was not able to complete the treatment, for example. So when they come to you, they're already anxious or maybe traumatized. So pediatric dentists can use those pharmacological aid actually to help with the treatment and reduce the anxiety and have a more pleasant and a smooth experience for the patient. The pediatric dentist actually can have a transitional rule in which they can actually improve the aesthetic, improve the function, reduce the pain and sensitivity, and preserve the tooth structure till actually the child will go into the adulthood stage where they can go for more definitive restorative treatment.
Yeah, thank you, Doctor. Does anybody else have a question for our doctor? I actually do have another question if nobody else would like to give it a go.
Yeah, please go ahead.
Premature birth, how does this impact the condition of AI?
Well, in AI, there are some specific genes that can affect, this is as per my knowledge, okay? Premature birth, it's mentioned in literature that it can affect the enamel formation or defect, but an MIH, molar incisor hypomineralization, which can affect only the permanent molar and central incisors sometimes. About the premature, I've never read anything about AI. It's usually because it's AI is autosomal dominant, autosomal recessive, or sometimes sporadic. But I know that premature birth definitely is a factor affecting the MIH, which again affect actually the
Thank you very much. If no one else has got a question for our doctor here, then I would like to say thank you very much, doctor, for your contribution and your insightful presentation. I really enjoyed this presentation. Thank you so very much.
Thank you so much for listening. Thank you, everyone.
Thank you. So our next speaker, we have Mrs. Dalu Shukumaran, who is a wound care nurse also from the United Arab Emirates, and she will be presenting on optimizing tissue viability in long-term care settings, NMC Provita's strategy for effective MASD management in geriatric and pediatric patients. Kindly join me in welcoming Mrs. Shukumaran. Thank you. Hello, Mr. Kumaran, there you are. Thank you. You may proceed.
Good morning. Am I audible?
Yes, you are audible and we can see you clearly. Thank you.
You. Is the screen is visible to all?
Yes.
Thank you for having me here as a presenter. I'm Dalu. I'm working as a clinical tissue viability nurse in an MC. Before I was an RN registered nurse, and in my clinical ladder advancing, I have learned tissue viability graduation, and now I'm working as a full-time tissue viability nurse in NMC Provita since 2023. So we will discuss today of the topic of our quality improvement project we have done in NMC Provita, the optimizing tissue viability in long-term care settings, strategies for effective MASD management in geriatric and pediatric patients. So basically we have two facilities in NMC Provita, which is long-term specialty for pediatric and mainly long-term care patients. With these two facilities are located in one in Abu Dhabi and one in Al Ain. So background of our project. Before proceeding to the project, I have to say I have no conflict of interest to disclosure. So background of our project, I'll just introduce what we have. What is moisture-associated skin damage? Moisture-associated skin damage is characterized by skin inflammation with or without erosion due to prolonged exposure to moisture source such as urine, stool, perspiration, or exudate, or mucus. This condition is a significant challenge in long-term care settings, particularly among elderly patients, pediatric population with fragile skin integrity. So before starting the project, we have done our prevalence study. It says a literature review highlights the prevalence of MASD with studies reporting of 5.4% incidence in 448 nursing homes across 28 US states, and a 45.7% of prevalence of continence-associated dermatitis in individuals with incontinence. The number says like 1,140 patients are affected among 2,492 patients. So by this prevalence rate itself, everybody can understand how important it is to prevent. So we have done a problems study before doing our project. By seeing the picture itself, we can say that our number of cases in 2020-23 says at the end of the fourth quarter, we have around 30 cases, and which is lead to 3.0.8 ratio in our fourth quarter, so which is a higher rate in our facility. So we decided to prepare a quality improvement project for preventive measures. And with this ratio, NMC Provita prompted a initiate a target quality improvement project using a focused PDCA framework to strengthen identification, prevention, and management practices. So objectives of our study, we decided to reduce incidence rate of MAST and enhance patient outcome through systemic identification, prevention, and management strategies in a long-term care setting. Achieve a 25% reduction in MAST incidence by December 2024, targeting a rate of 1.62. And standardize documentation and reporting, ensure timely use of protective product. And we have selected a sample for the product we used from our Abu Dhabi and Al Ain facility. Numerator inclusion, we kept all the long-term care patients with moisture-associated skin damages. And numerator exclusion, we kept MAST present on admission, which we are in admitting patient with MAST, we excluded. Denominator with a count of total number of long-term residence days during the measurement month, we kept. Methodology we use in, we applied a focus PDCA model, identify high MAST cases in quarter 2023. We use we form a multidisciplinary team, and we map the current practices and product used, and understand and analyze the cause of variation, and select a standard protocol. And we use PDCA cycle use for planning, implementation, and evaluation. So I kept the infographic picture for the fact. Focus PDCA, we use focus PDCA methodology to improve our quality improvement project. So I will just elaborate all the steps what we don't to achieve focus PDCA. We make a team of, organize a team on stakeholders. We kept the project leader and wound care nurse as me. Facilitator of we kept the director of nursing. Team members included wound care link team, which we have created a wound care link teams in each facilities. So they will be part of our project, and quality department included, and physician and dietitian we included, education team and nursing team and procurement team. So all together we created a team before the project initiation, and we studied the current practices before starting the project. These are the current practices in our facility. So there are documentation, not standardized documentation was not there. Escalation to wound thickness is not consistent. Product selection varies and lack of variability. Barrier products are used inconsistently. Limited staff training on MAST and preventive measures. So we have done a root cause analysis how to improve our strategies, so that we identified main 4 points: staff education, limited knowledge, and inconsistent assessment. We identified process factors, we identified no standardized protocol, we identified, and product factor included limited protective barrier availability, we identified, and patient factors, incontinence and immobility comorbidities we identified is a major factor because of incontinence and comorbidities are more common and common for long-term care patients. So that will be an affecting factor in making MAST difficult to treat. So intervention, we have started with actions plan, and education needed analysis was conducted. We have conducted among 123 staff, we have received 86.2% of staff identified as need for MAST education. So staff training of MAST recognition and use of Globi tool. Globi tool, which is a tool, is developed only for moisture associated skin damage identification according to his category and grade of level of effect. So we introduced a standardized MAST prevention protocol to our facility. Protective barrier cream introduced for high risk resistant. Protective barrier means it's like a waterproof layer of skin, so which will prevent the effect of urine and stool contamination to the skin at minimum level of barriers we can achieve by using a barrier cream. So protective barrier cream introduced. Introduced for all the high-risk patients as a preventive measures, and updated wound notification template and review documentation cross-audit tool. We have updated notification templates and cross-audit tool, and we have prepared and circulated fast path preparation in our learning development system. So it is assigned for all the staff. So it improve the knowledge level of the staff. So other part, I have attached few pictures of our activities in our institution. We have done the staff education and training, which is conducted through competency checklist, villa meeting, because villa meeting means all the fit facility having ward setting for us. We have developed, we have giving care in villas and providing care like home settings, which patient will feel like their own home care. So we have 10 villas in Abu Dhabi and 5 villas in Alain. So every month we will having a villa meeting. So we have done training in villa meeting, and we have conducted wound workshop. We have 9 hours AME accredited workshop for conducted for all the staffs, and we have participated in international interprofessional wound care conference in Abu Dhabi, which is conducting every year in Abu Dhabi. And we have done many product training for all the implemented product, and we have participated in JCA and poster presented. We have done other staff training in the nurses station by our woundling team members and wound leads. And we have done a pressure injury prevention day program, which will make awareness to the staff what all the preventive measures. So as a part of the pressure injury prevention day, we have educated the moisture associated skin damage preventive measures also. So other implementation process phase, we have created this, as you can see in the picture, we have created a fast pack for the different types of moisture associated with pictures and preventive measures, and it is circulated to all the staffs and which is dispensed in the communication board in each nurse station. Also, these are the product. We have done a product evaluation process according to NMC protocol, and we have implemented. First picture is showing like all the barrier cream and barrier films, which is containing dimethicone. Dimethicone is a clear barrier content. So this one we have done the product evaluation and implemented, which is available in our facility. The second picture is calmoseptin, which is zinc barrier cream, and different zinc barrier cream. We have done the product evaluation, which is implemented and available in our facility. The third one is cleansing foam, which one is having easy, and we have done the staff. We have reduced the staff workload and easy to use cleansing foam, which is a standard pH, which is having a standard pH pH level, and we have reduced the use of soap and water. So the cleansing foam easy to use, and it will maintain the skin pH, which also one of the leading cause of MAST. So maintaining pH level is important to maintain the skin integrity. So and another these two are foam dressings, which we have implemented the silicone foam. So it is more skin friendly and pain free material. So other thing in the picture, I can standardize in the documentation process. We have implemented our Globite tool to identify the types of MAST and early escalation. We have created flashcard for preventive standards, and which is circulated to the staff as a pocket carrying flashcard, so they can refer anytime. So it is available in our staff pockets, and I just included the product evaluation. I just standardized for all the products before introducing all product. We will go through the product evaluation process, and we have a specific product evaluation committee in Provita. So after the evaluation, the product evaluation committee will approve the product. Then only we are implementing in our patients as a part of evidence-based practice. So end result of our project, we can say in the picture, the initial initiative lead to significant reduction in moisture-associated skin damage incident rates, decreasing from 3.8 in Q3, which is a 2.9 annual rate of 2020-23, to an overall rate reduced up to 0.77 in 2024. So 1 year our project, it reduced a marked reduction in the number of cases. The cases reported was in 2023 was total of 98 cases, and we are able to achieve and reduce up to 30 cases in the year end 2024. Additional improvement include faster healing of MAST. We have able to achieve 1 to 3 weeks healing rate, early identification of MAST cases, reduce infection and improve patient outcome. I have included the graph of showing, which is having blue line is our target level, which is 1.62. The orange line 2.9 is our 2023 annual rate of MAST. In the second one, 1.662 is our target level, and our achieve 0.077, which is far below than our target level. And we are able to achieve more than 50% in the end of year 2024. So sustained clinical impact of the MAST quality improvement initiative in 2025. So we have achieved our target in 2024, and we stop our quality improvement project on 2025 and continue the preventive measures to 2025. So I have included the 2025 data in the slide. The MAST quality improvement project implemented in 2024 achieved a clinical rate of 0.77 through consistent preventive strategies and staff engagement. The program successfully maintained improved outcome in 2025 with a sustained rate of 0.75, demonstrating continuous quality care and effective clinical practices. And we have submitted this, prepared an abstract and submitted for the tissue viability conference in 2027, and we have approved. And the poster is presenting on, taking place on 22 and 23 April at Life Center in Bradford, UK. So we are happy to share that information to the audience. Our project is approved in other conference in UK. So as a result of the end result of education, we have able to achieve overall 93% of staff training in 2024 related to wound care and moisture associated and skin damage prevention and implementation process. And I have included a case result of patient, a 70-year-old female patient with multiple comorbidities developed moisture-associated skin damage in our facility due to incontinence of stool and urine. And with appropriate management, skin damage completely healed within 2 weeks. And I have included the photograph of before on onset date and after treatment plan. So we can see the skin is clear and no damages is evidently done. And this photograph is taken with the permission of patient. We have done the photography consent for before taking the picture. So in conclusion, the project highlights the importance of systemic evidence-based approach in managing moisture-associated skin damage, particularly incontinence-associated dermatitis in both geriatric and pediatric patients. Through structured education prevention strategies and focused PDCA quality improvement framework, we successfully enhanced clinical care standards, improved early identification and differentiation of MAST types, achieved better patient outcome in long-term care settings. So in next step, we expanded the protective product use across all the risk patients based on brand and scale assessment. Means we have in nursing assessment part, we have always brand and scale assessment. So in the moisture part, it's we identify the patient is at risk of moisture score is low. So all the patients, according to the Braden scale, we are implementing the barrier protection and preventive measures for prevent moisture associated skin damage, which is implemented, and we are successfully able to uh, manage the moisture associated skin damages, and conduct quarterly audits and monitor complaints and sustain improvement, and integrate MIST prevention and management protocol into facility-wide policies to ensure standardization and sustainability. So which is already completed, and in the process of policy integration, we have developed a clinical practice guideline for moisture associated skin damage, and now we are in process of integrating the policy. All the protocol we already developed, and now it's in the quality department to integrate the in our policy. These are the references I have.
Thank you very much.
Thank you. Have any questions?
This was very, very well done. I thoroughly enjoyed your presentation. From the audience too, does anybody have a question?
Yes. Can I put a question for Ms. Dalu? I'm audible.
Yes, you are. Please proceed.
Ms. Dalu, I just want to ask you, thank you so much for the insightful presentation. I just want to know, can you bring us to which are the key techniques used to optimize tissues visibility in the long term? What are the key techniques you are using in the long
So
term?
our identification process starts from the beginning of our admission patients. So our risk assessment tool, we are using Braden scale, which is common for all the nursing practice to identify the risk for pressure injury. In that, one part is moisture. So we are identifying moisture factor is less, it's high risk or risk. We will implement this patient with the barrier protection. So two types of barrier protection we are using, which is clear, which is Damathicon content. So it will not show any white patches in the skin. So it's skin friendly and easy to use, and no patient will not feel unsatisfied, or patient relatives will not feel unsatisfied. We are using clear barrier. And that one will prevent daily 2 times we are using. So it will have a coverage of 24 hours. And if the patient we identify with skin damage, we are using barrier one, which is 1 layer updated. Barrier films, we have 2 types that we will advise. If we have any other patient with the damages, we are using zinc barrier cream, which is having more thicker layering of coverage in the skin. And we will use mixing of barrier film and thicker paste for the patients. And once we identify, we are always using this barrier protection and barrier creams. And early escalation of redness. Our staff all are trained to identify from initial stage, and we are having a policy of report red. So any redness in the skin, they are not hesitate and free to report, and we are not making them fear to report any cases. So always supporting our woundling team members, having a second eye to assess the patient once it's reported. So we are implementing the early management. Before damaging the skin further, they are reporting that is our key success rate to reduce the number of cases. And still we have the number of cases in having, like you can see 30 cases, 20 cases in 2025 also, because our all patients are very fragile skin and having sphincter loss, like anal sphincter and urinary sphincter. So they are always having incontinence. So we are very happy to achieve this rate with our challenges. We are having not acute patient, all are long term with multiple comorbidities. These all the comorbidities, which is one of the leading cause of MAST. With these all challenges, we are able to achieve this rate. A great support from our team, and our team is escalating the incidents earlier. And we are using only barrier cream for preventing, and we are using identification tool as Braden scale.
Thank you.
Am I answer your question?
Yes, thank you so much. Thank you.
Any
Are
other
there
questions?
any questions? Yeah, I was about to ask. Anybody? I do have
Yeah,
another question. Yes, please go ahead.
Yeah. Actually, I just have one or two questions. Question number one, is the pressure injury is ever preventable 100%, especially an elderly comorbid patient who's actually completely bedridden? With the available technology that we have or available equipment like the air mattress and such things, and in case we do have the pressure injury, how long, depend if it's level 3 or level 4, can this be treated? And what is the time frame for treatment usually for patient to respond?
First question to prevent, is it preventable for pressure injury for long-term patient? Yes, of course. I can say that we have no pressure injury since 2 years in our 2 facilities, and we celebrated this last 2025 September, zero pressure injury for 2 years in NMC Provita, and we have achieved this success due to our strict preventive measures. And we have identified the patient by using Draden, and we are implementing this air mattress barrier, and additionally we are implementing the sacral and heel protection for all identified risk patients. So which are the basic things we are using, and our policy of reporting red early escalation. This strategy we used. And the other exclusion for the long-term patients, which is non-preventable pressure injury, the patients like cancer patient, palliative patients, and end stage of renal diseases and dying patient, these patients we cannot say it's preventable. Other than with multiple comorbidities, all long-term care patients can be preventable 100% with strict preventive measures and early escalation process. And the second question, how long it will take for treating a pressure injury stage 3 and stage 4? It depends on the patient clinical condition, and we are treating the patient as a whole. So it depends on the condition of the comorbidities and clinical status of the patient. And normally it will take 6 weeks to 18 months to heal a level 4 pressure injury. In all the scenarios are well go. And we have treating the patients with stage 4 level with 6 months. Within 6 months, we have achieved success rate. And we have treated the patients with 1.5 years to heal completely. And still we had the patient maintenance wound never healed till 4 years still. That type of wound we categorized as maintenance wound, and we are keeping the pressure injury with a minimal management and treating, maintaining us prevent infection and keep the wound as it does, because this type of patient cannot be healed due to some other comorbidities.
Does that answer?
Anything I missed?
Okay, I don't know where he's gone, but I also have one question. Why is it important to maintain oral health outcomes, or how important is it to maintain, in terms of their diet for these patients? Because if they are, my assumption is they are bedridden, and most of them will have like maybe a PEG tube or suprapubic catheter, the feeding and so on.
For the patient having with a long-term care patient having a pressure injury, they need a wound healing, additional nutritional support. Rather than the dietitian will calculate their diet according to the daily requirement. So when they're having affected the wound, they need additional protein and additional multivitamin supports or other additional nutrients to make the wound healing faster. So what we are including our team, multidisciplinary team, as we are escalating to the dietitian. We have our team like dietitian, therapy team, doctors, and nursing, and me will always have a discussion before planning the treatment plan. So depends on the level of wound we are creating our position change, offloading technique, and dietitian used to add additional protein and additional supplement to improve healing. And we have done, we used to do that lab work to check the albumin, procalcitonin. All the blood values also will be a cofactor for healing. So all those things we are doing in a multidisciplinary approach, and how we are creating our plan of care. Most of all the patients we are creating an individualized care plan. So there is no current or fixed product to use to treat the pressure injury. It always depends, and you can utilize available resources. Always customize and structure our own recipe to treat the wound. I won't say this will not, this only one product will heal, this only one product is important. So always we will say in wound care, what is the costly treatment, wrong product selection. The wrong product selection and wrong diagnosis is the costly treatment for pressure injury. So we are practicing early escalation and multidisciplinary action and customized plan of care to treat our patients.
Well, I think you really are a subject matter expert, and thank you so very much, and congratulations and well done on being accepted for the project in the UK. Thank you very much, Ms. Sukumaran. It is now 10:27, and I think we will take a coffee break from 10:30 until 10:45. Can we all be back at 10:45 when our next speaker will be Dr. Hazem Rizlan, pediatric dentistry? Is that okay if everyone can be back at 10:45? Thank you.
Thank you.
Welcome back, everybody. Just give me a heads up if you are back so that we can continue with our next session. Well, I hope everybody enjoyed their coffee break or tea break, water break, whatever it was, a refreshment. And as we continue with our next speaker, it is Dr. Hazem Reslan, pediatric dentistry specialist from the United Arab Emirates. And he will be presenting on traumatic dental injuries in pediatric and adolescent patients, epidemiology, clinical diagnosis, and evidence-based management guidelines. Kindly join me in welcoming Dr. Hazem. Doctor, the stage is yours.
Good morning, everyone.
Good morning.
I hope you are all okay due to the circumstances we are facing here in the United Arab Emirates.
Doctor, may
Actually,
I ask that you please switch on your video?
Sorry? Yeah.
May I ask that you please switch on? Thank you, Doctor.
Type. Today, we will discuss the traumatic dental injuries in light of the guidelines of the International Association of Dental Traumatology. Actually, traumatology is a very big subject to discuss over the next 20 minutes, but I'm trying to give you a clinical guideline that helps you to make the right decision at the right time. So, shall we start?
Yes, please.
Yes. Let's imagine that a 9-year-old patient comes into the clinic. How to share the screen? Yeah.
Yeah.
So let's imagine that a 9-year-old patient comes to the clinic after a fall. And the parents' main concern, will he lose a tooth? Today, actually, I hope I will give you the clinical guideline that helps you to make the right decision. And this presentation actually aligned with the last guidelines from the International Association of Dental Traumatology that published at 2020. So why trauma matters? Because trauma is common. Almost 1 in 5 children, and actually it's not a fracture. It's a function, it's an aesthetic, and it's a confidence. But trauma usually happens in 2 main peaks. Early childhood, because of falls, the lack of balance, and later between 10 to 8 to 12 because of sports mostly. And the most common injury is crown fracture. Not all the patients are the same. There is a high risk factors like increased overjet, poor lip coverage, because the incisors are usually more exposed forward. And the other high risk factors, the ADHD, cerebral palsy, seizures, autism, and the contact sports. Why we need to know the high risk factors? Because sometimes prevention is better than treatment. In trauma, time changes biology. So delayed treatment may lead to bulk necrosis, root resorption, ankylosis, eventually tooth loss. Before starting our treatment, we need to assess the patient if there is any neurological injury. Is there any loss of consciousness, vomiting, dizziness, blurred or double vision? We immediately call the 999 here in UAE, looking for further assessment and treatment. We need to ask 3 important questions. Where the trauma happened? Because it may happen in contaminated environment. We need to know about tetanus status. When? Time is the most critical factor in dental trauma. And how? In high impact trauma, the suspected additional injuries may happen. Forwarding to the extraoral examination, looking for bruises, lacerations, facial asymmetry, and the TMG is important to be assessed with palpation, limitation of the mouth opening, may require further investigations and imaging. Let's start with the clinical framework to work in. Is the tooth present? Is there any displacement? Is there any fracture? What's the maturity of the root? Then is the bulb exposed? These 5 questions guide the treatment. If the tooth is present, mostly we are facing a luxation or fracture situation. Tooth absent, mostly is avulsion. Treatment. Managing always follows biology. Fracture framework. Let's forget about the classic calcification. Let's ask, where are the borders of the fracture? If it's in the enamel, so the restoration is enough and there's a good prognosis. If the borders are in the dentin, we need to cover the dentin immediately, preventing the bacterial contamination and restoring the functional and aesthetic of the tooth. If the bulb is exposed, then we have 3 things to ask. The size of the exposure. The bigger the exposure, the deeper the treatment is. The time. When there is a period between the trauma and the treatment, that will complicate the treatment. The maturity of the root. When it's open apex, we need to preserve the vital bulb as it's possible. With the root fracture, usually it's seen on the periapical X-ray, and if it's not seen in the periapical X-ray, CBCT will help. We need to reposition the coronal part if needed. Splinting for 4 weeks with the flexible splint. But in the coronal third fracture, we need to splinting for 4 months. The subluxation injury, usually there is no displacement in the tooth, but there is a minor mobility, bleeding, the gingival sulcus. Soft diet is required. Splinting with excessive mobility may be optional. The extrusion injury, The tooth usually look elongated out of its socket. We need to reposition splint with a flexible splint for 2 weeks. If there is a fracture of the marginal bone, consider splinting for additional 4 weeks. The lateral luxation, we need to reposition, splinting for 4 weeks. And in the intrusion injury, the tooth will look infra-occlusion. There is absence of the ligament area. And here we have 2 scenarios. If the tooth is immature and the open apex is good, the spontaneous eruption may occur. But in the mature tooth, repositioning with surgical or orthodontic procedures, and then RCT is mandatory to prevent the inflammation aligned with the necrosis of the pulp. Avulsion, actually in avulsion case, we are not just treating the tooth. This is a race against time. You can see here that the socket is empty. The X-ray shows that there is no tooth in the socket. We need to rinse with a normal saline. Avoid scrubbing the root just to maintain the cells of the periodontal ligament. Replant immediately. Splint for 2 weeks with flexible splint. And not forget to mention the time between the trauma and the treatment. The tooth should be preserved in right media, like HPSS, if it's not available, milk, saline, or saliva. And strongly using normal water is not recommended. And never replant the primary tooth. Follow up sometimes it's as important as the initial treatment. And follow up should happen, should see the patient in 2 weeks, 4 weeks, 3 months, and 6 months, and for 1 year. We look for necrosis, ankylosis, discoloration, and resorption to initiate the treatment as recommended. What are the common mistakes we need to avoid when we are dealing with the dental trauma? We should act fast. Don't scrub the root in the avulsion. Don't oversplint, and don't ignore follow-up, because time changes biology and timing saves teeth. And it's a good day to save a tooth. Thank you all. It's a quick review of the latest guidelines of the International Association of Dental Traumatology. I hope I gave you a clinical guideline that helps to act fast and accurate.
Thank you, Dr. Hazem, for your insightful presentation. This is clearly a new field also for me, coming from the OR. We're not always that, aware of the traumatology for dentistry and such. But thank you so much. Does the audience have any questions for Dr. Hazem? The floor is yours. Otherwise, I will have a question to ask. Anybody? Okay. Doctor, what are the most common types of traumatic dental injuries that you've seen in pediatric patients?
Actually, it's a crown fracture.
Crown
Is
fracture.
the most common injury. But sometimes it's not only a one traumatic injury. Usually it's combined with luxation, crown fracture. We need to look at the patient as a unit, not only focusing the tooth that's traumatized. Maybe 2 to 3 teeth may be traumatized, one with fracture, one with subluxation, one with lateral luxation. And actually in pediatric dentistry, there is a challenge. It's how to manage the traumatized patient, because he is usually feeling terrified, feeling panic after the trauma. So usually we need to first relax the patient, make him feel safe, then proceeding with the procedure we need to do. And as it's complicated cases in pediatric dentistry, some of them actually needs physical stabilization with bubbles board in order to act and do the treatment as needed.
Thank you very much. If there's no further questions, we would like to thank you so much, Dr. Hazem.
Most welcome.
Presentation. Really, really enjoyed it. Thank you and have a nice day further.
Thank you.
Thank you. So, our next presentation is Dr. Kat. I am really bad at pronouncing names, so I will not attempt to pronounce your last name. She is representing Kat Phoenix and joining us from Malta. She will be speaking on patient-oriented digital health and AI applications. How fitting in an era that we are living now. Dr. Kat, the floor is yours. Thank you.
Hello, thank you so much for this very nice introduction, and please do not worry with the pronunciation of my name. I have lived abroad for a very long time, so I make it available for everyone to pronounce. Even my first name actually is it's a shortened version. Please allow me to share my screen. Give me a second. Okay, share. Can you see my presentation?
Yes, and you are audible as well. We can see as well.
Fantastic. Very good. So, hello, everyone. Hello again. I'm very grateful for the invitation to this high-level conference. And it's my honor to talk to you today about patient-oriented digital health and AI applications, which we bring to the forefront of this discussion. And I believe it's especially important, just aligned with what Dr. Hazem mentioned. We face many situations when patients are feeling a little bit stressed, and they have to face all different meanders of healthcare systems. So today, I would like to bring this topic forward and offer you a little bit an overview of a landscape of how different applications can support patients along their way. But I will also mention about other topics which are related to their use. So I would like to say that for over a long time, we have been using all different kinds of applications. And today I would like to speak not only about the apps and algorithms or artificial intelligence, but also about patients, as they're in the center of our attention. Patients are not abstract concepts. There are you, me, our loved ones, children, and parents. And my central message today is simple. Digital transformation must begin with the patient journey. And we have healthcare services to support them. But before I start my presentation, let me introduce myself. I am Dr. Kat Zarefta, CEO of Cat Phoenix and Accelerate Nexus. I'm a EU expert advisor and clinical hypnotherapist and mentor. For over 20 years, I have been working at the intersection of advanced innovative technologies and patient-oriented care, developing digital tools and therapeutic platforms that support recovery and, in some cases, help to save lives. So let me come to the outline of this presentation, as I would like that we explore different meanders of what will be important to take in consideration in patient's journey. So patient journey is not only the hospital systems, and I would like to bring this topic forward. Also mentioning about how and why AI must remain human-centered. I will mention to you and uncover the categories of patient-oriented digital health, present digital health applications, which are supporting patients across the lifespan, and also mention to you about the regional perspective. But before I start, I would like to mention few words about artificial intelligence itself. AI is a powerful tool, but it is not a digital brain. Neural networks are mathematics, not magic. They are excellent at narrow tasks, diagnosing skin cancer, analyzing scans, detecting different issues related to our health. But they struggle with nuance. Why is the patient sad? What cultural story shapes their pain? What family dynamic influences their distress? That remains deeply human, and some physicians fear AI, others use it without guardrails. The truth remains in the middle. AI is powerful, but without human supervision, we cannot fully rely on its judgment. And while debates continue, AI continues to improve. The future is partnership. AI amplifies human care. It does not replace it. And I would like you to take a look at this slide, and especially the image on the left. So let me start with this comparison. Usually the patient's journey navigating the healthcare system feels a little bit like walking through the Escher painting. Corridors going nowhere, stairs up and down, and confusing directions. Traditional digital health was focused on hospitals, records, billing, internal workflows, and efficiency. So in short, we could just say that it was a digitized bureaucracy. Patient-oriented digital health focuses on starting with the patient's journey, understanding options which they have, accessing support, navigating pathways, staying on the treatment, monitoring outcomes safely, extending care beyond clinic walls. This is a fundamental shift. We are moving from institutional optimization to a human-centered continuity of care. Based on World Economic Forum analysis, there are 4 essential pillars for implementing patient-facing AI: building trust through empathy and interactivity, mitigating bias, keeping humans in the loop, and planning for scalable deployment. The biggest barrier is not technology, it is trust. AI hallucinations are real, bias is real, energy consumption and scalability challenges are real. No single stakeholder can implement AI responsibly alone. This requires collaboration between providers, governments, payers, biopharma, and tech companies, and of course, patients. The promises of artificial intelligence are extraordinary. It is fast, available 24/7, helps to reduce stigma, offers personalization, gives access in underserved regions, but risks are equally real. the lack of empathy, false reassurance, data privacy concerns, cultural mismatch, embedded bias, or black box decision making. So, who owns our data? Who interprets this? Who is benefiting from it? These are not technical questions. They are ethical ones. Patient-oriented digital health falls into 3 layers: health education and symptom support, triage and navigation, disease management and follow-up, and we have access to it before care, at the entry into care, between the appointments. Patients' health, including their mental health and well-being, benefit from all 3 of them. Some doctors, like my friend Dr. Javier Castro, aka ChatGPT, Dr. GPT, or Philippe Gerville, a futurist in healthcare, embrace this innovation and breach towards the applications of new AI-based tools. These platforms democratize knowledge. They translate complex medicine into plain language. They reduce anxiety, improve literacy, help patients articulate symptoms, but they must rely on clinically curated data, not open internet scrapping. This is where the design matters. Healthcare systems are very complex, and digital front doors help to simplify them. We have all different opportunities to support patients with appointment booking, with intake, insurance, urgency routing. This prevents minor issues from becoming emergencies and help to de-escalate serious cases early. Help also to reduce anxiety, take informed decisions, and really improve literacy. AI apps play a fundamental role in mental health and behavioral AI. Conversational AI and therapist marketplaces provide immediate conflict coping tools, continuous engagement, reduced stigma. For many people, sending a message to an AI at midnight is easier than calling to a clinic or even a friend. But the crisis detection must escalate to human professionals. AI is support, not replacement of the therapist. Young people are not doing well globally, suffering from cyberbullying, screen overload, self-diagnosis culture. Yet digital tools can help. Gamifying support for children with ADHD, like PlaySend, or Poppins, which helps neurodivergent kids to learn. There are also apps which help with emotional literacy and offer structured guidance. But youth-facing tools require even stronger ethical guardrails. Children deserve the highest level of digital protection, and we must not fail them at this. I particularly appreciate platforms that combine ease on onboarding, direct messaging, human psychologist supervision, and AI-supported but human-led. These hybrid models may be the most sustainable in the future. We also need to pay attention to very different needs of women, men, elderly, also at different moments of their life and their life stages. Women face hormonal transitions that affect mental health with PMDD, postpartum, peri, or menopause. Digital tools can help track patterns and support autonomy. Men often underutilize therapy, so anonymous digital entry points can really help to reduce the stigma. Older adults face loneliness and cognitive decline. Here, simplicity and caregiver integration are really crucial. So again, design must adapt to all these different life stages. I would like to also bring your attention to the digital therapeutics, because they are not just wellness apps. They are clinically validated, prescription-grade software. They are evidence-based, regulated, scalable, and this represents a maturation of digital health from experimental to medical grade. They offer clinical efficiency, they bring the scalability forward, but they also offer cost efficiency. And this is really very important for the overall healthcare systems. For any patient who is suffering from chronic diseases, there are also many new options helping them in remote monitoring. And this is shifting healthcare from reactive to proactive. Wearables, AI, and IoT are easy to detect early deterioration. Patients can remain at home. Independence is increased, hospitalizations decreases, and the prevention becomes data-driven. Quality of lives overall increase drastically, and this is the most precious outcome for any patient. I would like to bring your attention to also a new movement, patient portals and tech-enabled care, which actually was initiated by patients or the caregivers. Patient portals transform passive records into interactive communication tools. They offer transparency, which improves trust. They offer convenience, reducing friction, and data ownership, which empowers patients. I give you in here an example of Nabu, which was created by parents willing to support the healthcare journey of their daughter. And they were joined by healthcare professionals who are supporting this, creating a very powerful tool which could be accessible globally. This is an AI-generated map. And I would like to showcase you the geographics of digital health and AI applications. And as you can see, United States is really leading in this regard with a very high number of applications. And I only choose the most relevant ones. We can also see that Europe is following with very high number of applications and products as well, especially with UK leading this way, but also with other countries. We also see the presence in Canada, Australia, Asia, also some in Africa. But I would like you to playfully take a look again at this map. To an untrained eye, it looks almost correct. But if you look closely, you will notice something. There are some geographic distortions. France is mixed with Germany. Oceania replaced Egypt. And it's an 8th iteration of this AI map created by different models. So I would like to ask you a question. If AI struggles with mapping geography accurately, can we really fully trust it with our health without regulatory and ethical guardrails? I really believe that human supervision is non-negotiable. I would like to come to the conclusion of my presentation. Patient-oriented digital health succeeds when it starts with the patient journey, protects the privacy, adapts to culture and life stages, supports families, and strengthens clinician relationships. Digital tools can educate, triage, monitor, personalize, and scale, but they cannot replace a parent's intuition, a friend's persistence, a nurse's care, and a clinician's presence. The future is not digital versus human. It is digital tools that make human care more compassionate and continuous. AI may become a part of everyday healthcare, but relationships will always heal. I would like to thank you very much for your attention. Please feel free to scan my QR code and connect with me on LinkedIn. I look forward to continuing this conversation because digital transformation is not about technology, it is about people. Thank you so much.
Thank you very much, Dr. Kat. Anyone in the audience has a question? But before that, I just want to say thank you very much. I think because AI is so on the forefront nowadays, and I think for certain generations, it's very difficult to navigate. I think here closest you get to the Gen Alphas, they, I think, probably the best to navigate their way through through AI. Yeah, I come from a different generation, so I'm still with a pen and paper and a book. But if anybody has a question that they would really like to pose to Dr. Kat, please go ahead and feel free. I think this is an area which we should really educate ourselves on, regardless what generation we are from. Anyone? Okay, I'll give it a go. What is patient orientation digital health? And how does it improve patient care?
So I would say that the change which we have observed over the past years, especially, really comes from alignment with other fields, I would say, even other sectors, if you allow me. The question which happened is that for all different kind of aspects of our life, we're able to use all different kind of applications. If we would like to order something to eat, we can use different kind of applications. We have online banking. We have, applications to book our, beauticians, therapists in all different sectors and aspects. We're scrolling, and this is actually an issue which I can also talk about a lot, and observe, we can buy clothes, we can buy grocery, we can actually access to everything through an online platform. And I believe for a very long time, healthcare was very stringent and sometimes, stopping the progress in this regard. But what happened is that people are patients and they wanted to have the same amount of, let's say, easiness, accessibility, as they have observed in other aspects of their life. So I believe that especially this, willingness to being able to have an appointment with the doctor, sometimes verify the symptoms, have also the support and understanding if the treatment is going well, if, we need to come back and see the doctor, or we can just, continue with the treatment at home. I believe many of those questions were bringing a lot of anxiety and had a very detrimental, actually, influence on our mental health. And what I really have observed working with patients, actually, especially in oncology-related topics, that patient really felt like in this maze, which I have presented. I really, by the way, love this because it's a very good comparison. And going through ups and downs in corridors in the hospital, that's how we felt. Like I was also a patient that happened, or I was accompanying, my parents. And when the stress is coming in, even if we're working in medical field, it's very difficult sometimes to put all our emotions away and look for, the reply to the question, of what is actually the most needed. We want to do our best, but I feel that with the right quadrails, the right, ethical applications, we have so many tools which we have access now that can really support us better. I really believe that this is something important, but there is another thing which I will always, bring in almost every of the slides as well in this presentation, is that it's not just going to App Store and just getting any kind of application. It is very important that these are health-related issues. And I compared this to the map because I found it so funny. I've decided to show this to you anyways, because some of the things I haven't even noticed. It's like, you look at this and I don't know, somehow artificial models cannot get the geography well. But can you then trust them that they know how your organs are, really lying in your body? So I believe that this is very important to kind of have the common sense and also protect ourselves. But I believe that the change and moving forward really is there. And so this is going to be our future. We need to understand it. We need to feel not scared about this, but ask the questions, looking for the answers, and embrace the change.
Embrace the change. Yeah, if we think about our elderly parents also now sitting with apps on their phones, trying to navigate life and then go to Dr. Google. Thank you very, very much, Dr. Kat, for your insightful presentation here today. It was really enjoyable. We really appreciate your time. May I just ask, what is the time difference between Malta and the UAE?
I think that currently is 2 hours, but I'm actually in Dubai.
Oh, you're actually in Dubai. Fantastic. Thank you so much. Really appreciate you.
Thank you so much. Thank you.
So moving on to our next presenter here today, we have the honor of welcoming Ms. Roa Hassan Aman from Eastern Health Cluster, joining us from the Kingdom of Saudi Arabia. And she will be presenting on engaging nurses in research awareness using a new style of hospital journal club, a descriptive evaluation. Welcome to the floor, Ms. Roa, please. The floor is yours.
Thank you. Thank you. And I would say hi and good morning for all of you, and thank you for introducing me. I will be engaging today. Our title, it will be Engaging Nursing in Research Awareness Using a New Style of Hospital. Just I want to ensure it is available, the presentation.
Yes, and you are audible as well. Thank you so much.
Okay, because I can't see my sharing. It is sharing well. Okay, I can start, right?
Yes, please.
Okay, thank you. I am from Saudi Arabia. I'm working in the cluster Esran. I am as a research mentor and also change management leader and nursing, and I have so much article and research published. And today I will come to share with you this study done in 22, engaging nursing and research awareness using a new style of hospital journal club as a descriptive evaluation. As we know, the evidence-based nursing practice has a leading role to play in improving healthcare quality and patient outcome. Integrating and applying the current evidence empower the nurse, increase the quality, is cost-effective, and improve patient healthcare outcome. Global bodies and leading authority advocate nurse should be proactive in identify research evidence and capable of appraising and applying to drive improvement in quality and safety and patient care delivery, and also effectiveness of health and social care system. And this study done in South Africa, Nursing Council regard the acquisition, current knowledge and the skill that reflect evidence-based practice and apply the practice setting a core competency for specialist pediatric nurse in South African nursing, and expects that pediatric nurse will undertake continue professional development and in support of these. This publish of the nurse, this title of the research article. The method that done in this study to investigate the impact of the red signs in monthly journal club of nursing relating to this stated objective of the intervention. The primary objectives were to determine whether the journal club impacted nurses, access scientific literature, and personal and organization habits of reading, and examine whether monthly hospital journal facilitated to collaborative explosion of a clinical nursing practice. Second objective was to explore the enjoyment and experience of the visual method, a graphic record, and facilities methods. The structure of a study design was followed using researcher design quantitative questionnaire to investigate nurses' self-reported experience of participating in this journal club. The sample population, all cards of nurses working in this hospital, registered nurse and enrolled nurse, and also nursing assistants. Nurses who had attended 6 or more journal club sessions that in the hospital over the previous 2 years were recruited. The revised standard for quality improvement, reporting excellence, and guideline were used to report study. Essential information regarding the context of the intervention are provided as in the table 1. And we show that one. We see how it is this contest setting. They approximately 2,050 patient per year. It is they can see, and also are over 12 inpatient hours, including medical, surgical, oncology, and general psychiatric, neonatal, and numerous outcome service. 45 clinic also. The goal of this intervention, state goal for redesign journal, including improvement nurse access to and engagement with the evidence beside practice and published research in order to assist nurses in providing optimal patient care. And innovation participating approach to the facilitation was employed, partial response to the relatively large number participant at the journal club session and the wide range of the nursing cards involved. These design features are distinctive among the published example of the Nurses Journal Club and appear to be novel. Frequently and delusion and newly journal club topic is prepared and delivery every month from from the February to November for identify 1 hour a session are held throughout the month. When Monday between 11 o'clock to 12 as a part of the hospital mandatory in-service training program for nurses. Attendance, each session is attended by the approximately 50 nurses of all CAS Journal Club as integral part of the newly mandatory continuing education program of nursing in the hospital. The venue, it will be in the session are held in the large hall in the hospital education building. Nurses site round table in group according to the ward or unit. Facilitated to group, the dialogues and shared reflection on practice stimulation by journal article. Facilitator, a large group of facilitation and practice development work with nurse who has additional training as in a graphic facilitation method. A typical journal club facilitation plan, it will be showing now as a future of new that session facilitated that nurses are allocated multi-cards group from 8 to 10 and corresponded to their usual ward beside team. Rather, each group attempted to analyze this while article responsibility is shared out, each group focusing in the different section in the article of answering different question. One participant peer group present feedback with equal value, place the continuing nursing participant from all cars. Many of nurses work a 12-hour shift in the 2 days prior to the journal club session. So the process is designed to elicit high-level engagement in keeping nurses focusing and attentive. Session often involve lively, spontaneous contribute as a nurse support their co-worker feedback presentation with sharing, clubbing, and encouragement. The second distinctive aspect of facilitating is that use of a graphic facilitation to guide and create visual record of the key point. A graphic facilitation involves their creation of large-scale graphic, usual hand-drawn future sample, and also can be assist to promote participant in a group discussion by providing shared visual point. And that's dependent about the group discussion. This the graphic about journal figure how to be the circle of this when they decide the day after the topic selection, article selection, consider including quality, religious article, apply to nursing practice, relevance to local context, and clarify of writing presentation practice, prefer paper, copies over all who will be photocopies of article made in accreditation of journal, promoters of this team. And also later it will be developed the question formulation that use to promote guide nurses through discussion, analyzing, and how it will be can applied or not by build familiarity with a process covering all of the foundational research. And the group facilitation, it will be aimed to create high-level engagement and energy. The process of summarize it article and share out across a group with their facilitator recording key point through the large formatted graphic record until the full summary a group discussion focusing and finding opportunity to apply a new insight to practice. This the table, I think all of us need to have experience from that one, how it is be a table, a typical journal club practice, and then they write it in 5 minutes. It will welcome and the ground rule, and how it will be also facilitate and introduce herself and welcome all of the group facilitator. The role of the facilitator in the 5 minutes, it will be very important. Also to the nurses are remind that their participant visual part of the topic and journal club session is stated as a brief outline. And another 5 minute icebreaker to see the tone, inclusion, the journal club session being with the icebreaker activity. It is a start the discussion among nurses, colleagues, breaker the familiarity and atmosphere, and separate the hour-long journal club session from the reading conversation in service on both training. And also 5 minutes for overview of the article, give overview the facilitator about the article using a graphic. 20 minutes it will be for group work, breaking into similar group, allow more than in-depth toward the specific conversation and provide opportunity for more nurses participant. Non-tech and volunteer report break large group is decide their question also and answering discussed in the small group will be shared with the large group. Another 20 minutes, it will be feedback of the large group. The large group reported back, provided an overview of the internal journal article. Volunteer speaker from each small group present their side of the question and answer. 4 minutes, it will be summarized and reference to key point on a graphic record by facilitator during report back, and facilitator element the feedback and summarize the key point of the session and linking the relevant section in the graphic record. And in the last 1 minute, it will be warm up and challenge the facilitator round up session and give challenge to apply at the least one aspect of the new knowledge to practice. About participant demographic in 20 investigated items, the total survey design and the method, and was utilizing in relation sampling, data collection technique, and the question construction, assistant a stakeholder manage also, and in development an item recommended by Stewart. First, why it will be professional families in the topic cognitive peer testing with 3 nursing staff volunteer and from registered nurse, aid nurse, and the final question, it was peer reviewed by the PhD prepared nurse. Academic with appropriate experience, questionnaire considered, and also activity to small modification to smallify the wording question and remove possible imputation, and the rewording question which reviewer advice could lead some nurses to feel that they were being tested, and simple step enhance reliability, including use reverse coding for a small subset of a question, and to use 4-point Likert scale or yes or no answer. Data collection, it was from 3 years, from to October 19, influencing institutional and committee approval, and took place over full for journal club session during October, November 2019. Data collection was conducted to researcher, and the survey collected totally 155 completed response, and that one response rate informed writing also by all participants. Data and analysis by statistics by using SPSS software version 26 after converting from electronic database. All response were anonymous to ensure that confident it was completed questionnaire was elected alphanumeric ID. The majority of nurses, 84, are strongly agree about the journal club was a main place where they talked with other nurses about research and evidence nurse practice. Nurses respond. Also, 87 of nurses strongly agree that was for the talk about sharing their award journal club. Response also is different between the nursing register and the aid, and who will have also don't compare it between the aid nurses and register nurses. And all that data it collecting, and as we see in here in the table how it is predictive, and we hear figure of the number 2 how the impact of the journal club in knowledge and having with other nurses about research and evidence-based practice. We see how often and sometimes, and how it is the numbers it is increased between before and after journal club attendance. Experience of journal club, nearly all nurses agree about the evidence base, and we see here also the figure table enjoying in journal club according to the card how it is strongly agree about it is where to be research and important of nurses to be have evidence-based nursing practice, and innovation graphic about visual facilitated method. In the discussion, the result it is descriptive evaluating indicate the participant. This monthly hospital journal club has increased nurses' access to the scientific literature and the personal and originalized habits of reading, facilitated collaborative exploration of clinical nursing practice, and provided an enjoyable experience through visual, graphic record, and active facilitation. Journal club aimed to achieve this outcome in the context richly diverse community with a specific consideration and established culture of practice. The design of this journal club also facilitated grouping and the structured question promote conversation, and the group can relate journal article contest to their own experience and explore those experience collective as a part of a team. This journal club appears to enable nurses to have unique and valued conversation about their practice, which different their usual as a social conversation. Significant of this research, journal club in this hospital RCWMCH appears to be unusual among hospital journal club worldwide because it is larger scale, because of this participant and visual facilitation method employed. There are several innovation features associated with the design. Learning from the study will be used to refine design and operation of their journal club, as well planned explanation to their site. Limitation, this was post-implementation evaluation, which increases the possibility of attribution or recollection bias. Recollection accurate was enhanced by excluding nurses without recent experience of journal club participate. Attribute bias is unlikely to have been problem as 84% of responded report to journal club attended was a new experience for them, and that they were not receive any similar input. The role of skills facilitating instrumental in the apparent success the journal club in meeting its objective. In conclusion, this first study to describe a journal club for all category of nurses offered as a part of hospital and service educational program South Africa. This finding from this study suggests that attending a monthly journal club has positively impacted nurses' access of scientific literature, personal and organization habits for reading, and collaborative exploration of clinical practice. And this is the reference. And as we are in the Saudi Arabia and in my hospital, I applied it this one for 2 years, and I see how it is our nurses coming more confidence and how it will be more increase also to attendance and to be applied this journal club and discussion and sharing the evidence base they have, and to increase the number of the research to be done in our hospital. Thank you for listening. Back to you, Chairperson.
Thank you, Ms. Roa. Thank you very much. Being South African, that was quite nice to hear. Thank you for your insightful presentation. It was really enjoyable. I just have a question here. In terms of the younger generation that is coming through, have you seen any significant impact that this new style of journal club has on them? Because we learn differently and we appreciate things differently from various generations. So have you seen the way they have appreciated comparing to others?
As my experience now, because I am started to apply the journal club now for 4 years, I see in the first year we do, it is very difficult and there is too much challenge. They don't like to be involved in that one. But in these 2 years, as you said, because we put it as mandatory. Here it is, but it is, as article and the research and reading this one, it will be taken from them time, and they said we are 12 hours and we have a patient care, and that one we have too much challenge, Antonio, by whom now and before. Still we have same that one, but we try to be all the time facilitator for them, be comfortable, be just discussion scientific as a journal club. We try all and motivating them to attendance and sharing and be by grouping in the journal club to try to to try to familiar or gathering stuff to discuss something with by practice.
Thank you so much. Is there anybody else from the audience that would like to ask a question? No? No one? Thank you very much, Ms. Roa. I wish you all the best. This is a fantastic idea. And I think I've got a few ideas also, spinning from yours. Really appreciate your contribution here today. Thanks a lot.
Thank you. Thank you. Thank you for
Okay.
your.
So our next presenter, and we welcome on stage Dr. Rasha Ibrahim Bishara from Sheikh Shahbud Medical City in United Arab Emirates, and she will be presenting on febrile convulsions and overview. And one of my colleagues actually, Doctora, said, I need to send you her regards. Supriya, she said, please send my regards to Doctora Rasha. So kindly, audience, help me to welcome Doctora Rasha to the stage. Thank you so much, Doctora.
Yeah, hi, good morning, everybody. It's a pleasure to be here today. And yeah, Supriya is one of my nurses I worked with before. She's fantastic. Just give her my regards, please.
Will do. Would you mind just switching on your video?
Yeah, just a minute. Is it now? Am I visible?
You are audible, but we still cannot see you, although we also can see your screen.
You can't see my screen, right?
Yes, we can. It's clear, we can see, but I cannot see you.
Okay, I'll just a minute. I think I have a technical issue.
Okay. You need a minute or so?
Can you see the?
Yeah, we can see the screen. Thank you.
Okay. I don't know, the camera is not.
Sometimes there is these glitches. I think it's okay for you, then proceed. If it's technology, these things happen.
Okay. So it's a pleasure to be here today to discuss a topic that we usually encounter very much in the busy emergencies, in the pediatric emergencies, actually. It's a febrile convulsion, very common, but it's still distressing to parents and actually to doctors also, despite one of the very common neurological events that we can see in childhood. So let's imagine the scenario of sitting in an emergency, 2 o'clock in the morning, and parents coming, rushing with a 2-year-old who is previously healthy and then developed fever earlier on the day, given all fever medication. When suddenly he developed stiffness of all his body with a rolling of the eyes, he started shaking, turned blue, and then they came running, crying in the emergency. What do you think at that moment? Everybody stands still. We receive the baby. When baby reached the hospital, actually, he's back to his normal and started crying, started breathing, and the parents were like terrified, and they have certain questions. Is my baby going to die? Is this an epilepsy? Or what could it be? So this is the hospital where I'm working, Sheikh Shahbud Medical City in Abu Dhabi, actually, center of Abu Dhabi, Banyas area. So it's an overview, actually, of the febrile convulsion. What is going on? So let's go to the definition. What is febrile convulsion actually? It's fever and a seizure at the same time. So it has an age. Actually, it starts between 6 months and 5 years, and it has a recurrence of 3% in childhood. Majority of, or the peak of getting a febrile seizure usually is between 12 and 18 months of age. Febrile seizure can be categorized into two sets. We have a simple febrile seizure and a much complex febrile seizure. So usually we see the simple febrile seizure. Of course, from the name, it has to have a temperature of 38 degrees centigrade or above. Important thing is there should not be any CNS infection or any metabolic abnormality or history of trauma. These have to be ruled out in the history. So the presentation usually is generalized convulsion, tonic-clonic. What does that mean? It means movement, shaking of the upper and lower limb in a rhythmic way, which usually lasts for less than 15 minutes, usually 5 minutes actually. The other important thing, it should not appear in the first 24 hours of that same illness. If we have fever for say 5 days, it should occur once in that period. So the other thing is usually children, they return back to their baseline very, very quickly. They might get some confusion in the early minutes after that, after the convulsion. This is what we call a post-ictal phase, where they become confused, crying, drowsy, but they go back to the normal easily. Also, it could be a first febrile convulsion without any history of other afebrile seizure, which is a different entity without fever. So the other one is the complex febrile seizure. Fever here is higher. It could go more than 38. Also, in the absence of CNS infection or metabolic abnormality. The difference here is that the complex febrile seizure can go up for more than 15 minutes, and it could be a focal, not a generalized. Focal means a part of the body is shaking only, with uprolling of the eyes. Also, it has a post-ictal phase, but it can lead on to neurological deficit later on, more commoner. So this is a tonic phase. They get stiff and they just arching of the back, and the clonic is like they stretch the limbs down. Eye movement, they can have staring, clenching of the mouth, of the teeth, I mean, frothing, abnormal breathing pattern. The breathing and with the convulsion are not symmetrical. There's another entity, not just a simple febrile convulsion or a complex one. Also, there is something called febrile status epilepticus. In this condition, it could be a single seizure that goes on more than 15 to 30 minutes, actually. And they don't come back to their normal, return to their consciousness during this whole 30 minutes. In that case, we have to initiate the treatment, of course, with a cannula, check the ABCs and oxygenation, start IV. Lorazepam is one of the sedation to stop the convulsion. These are the other medication we usually use, also phosphophenytoin or phenobarbital if the baby was younger than 2 years. So when a baby comes in with a convulsion like that, a lot of differential diagnoses we need to rule out before we can say it's just a simple febrile convulsion, and we reassure the parents. Could it be chills, shaking? Could it be meningitis or encephalitis? Does the baby have any metabolic issue in his body that can cause this? Could it be an epilepsy, the first presentation of an epilepsy? There are some genetic epilepsies which can be triggered with fever. So a detailed history is very important in these conditions. So children with previous febrile seizures are at risk of developing seizure in approximately a third of the cases. So, and children with a presentation of convulsion younger than 12 months have a 50% probability of having a second seizure. And if the baby was more than 12 months, then it decreases to 30%. And the literature does not support the hypothesis that simple febrile seizure is associated with lower intelligence or learning disability. That's the main issue the parents are really, worried about.
Hello?
Yes?
Doctor, are you still online with us, right?
Yeah,
Please
I'm
continue.
online, but problem is, I don't
The
know.
slides
Yeah.
moving.
Okay. So we have two types of germs that can cause, febrile seizures. Usually viruses and bacteria. These are the main known things that can cause a simple febrile convulsion. 90% of the causes are usually viral, like what we have during the seasons, like influenza A, influenza B, some sort strep pharyngitis is a bacterial organism that can cause this. Human herpes virus 6 also, this is very common, that the baby present with fever and they reddish cheeks and some rash there. Both vaccination also, especially with MMR and DT, they are liable to get some sort of febrile convulsion like that. So what is the pathogenesis of this fever? So when there is an infection or a post-vaccination or the vaccine, they go into the body and they trigger an inflammatory process. They produce all different types of cells that can trigger the neurons, and then they trigger the nervous system to produce this jerky or movement. It's just a little bit of pathology here. So the next one is the diagnosis. How do we diagnose? As we said, the history is very important. The duration, the character of the convulsion, is there any neurological condition associated? Is the baby immunized? This is very important. Immunization is very important here. Family history. Is there any family history of febrile convulsion in siblings or even in parents? Sometimes if the parents have febrile convulsion during their childhood, then it has implication in their children. Physical examination at that point is very important. Of course, we have to see if the patient is breathing well, his airway is patent, circulation, blood pressure, everything, and vitally, is he coming back to his baseline and consciousness? Because as we said, that simple febrile convulsion, usually they return back to their baseline neurological activity well. So a bulging fontanelle usually is seen in until 1 month, until 1 year of age, where the anterior fontanelle is this organ here on the top of the head. It's open in children, and if it becomes bulging or throbbing, this can lead us to think about some other rather than a simple febrile convulsion. You can think about meningitis at that time. So as we said, the management is the ABC, the physical examination, level of consciousness. We have, for the level of consciousness, we have a tool called the Glasgow Coma Scale. tailored for the children. It has a certain points to it, eye movement, muscle movement, and their ability to respond to verbal and commands. We have to make sure that the airway is really patent and there is no, so the child should not aspirate with saliva or if there is any other thing in the mouth. We need a blood pressure assessment, and this is usually in the ER from the start. So this is a very important question. Who needs investigation and who doesn't need investigation? So from the history again, if we concluded that it is a simple febrile seizure, we do not need to go to too much invasive investigations. We don't need blood, we don't need imaging. We can just make sure what is the cause of that. It could be just a viral. We can take some swabs from the nose just to make sure it's is it influenza A or B. And here we need to really reassure the parents with an evidence base that this is a simple febrile convulsion. We don't need to go further for any other diagnostic imaging in most cases. So that's because the parents usually, they ask, do we need to really investigate or not? So investigation are in the situations where we need to rule out other than simple febrile convulsion, like when it's prolonged more than 5 minutes and or 15 minutes. It could be other causes that may be causing it. So we need to do a full blood count and see the blood glucose and the electrolytes and calcium. This, as we said, not indicated in a simple convulsion. Neuroimaging. Do we need a CT? The parents usually ask, are you going to CT? Are you going to do a brain imaging or not? And usually no. In simple febrile convulsion, we do not need an imaging or a CT or an MRI, actually, because we don't want to go into that. It's very clear that the child is back and we know the cause, and it's not required anymore to do imaging unless we can see that some dysmorphic features are there in the child, like a big hair or macrocephaly, or the child is having a shunt for some sort of hydrocephalus. Maybe at that time we need to rule out other pathology in the brain then. So I don't know why I'm getting stuck here. Can you hear me?
Yes.
I'm sorry for that, but actually, so okay.
Okay.
So an EEG is important. Again, not in a simple febrile convulsion. EEG is like when we need to know, could it be an epilepsy, actually? Epilepsy is a different entity, and we usually diagnose it with electroencephalogram. These are electrodes applied to the head of the baby, and it gives us certain readings about the electricity of the brain, and then from there we can diagnose a lot of sources of epilepsy, different types of epilepsy. Again, this is not done in a simple febrile convulsion, but we need to do it in a complex febrile convulsion. So, and of course, this is not done in the emergency room, but then after stabilizing, we usually let the baby go to the neuro, clinic, where they can be elaborated more about that.
Doctora,
Yeah.
again, stuck.
I don't know what's going on today. Oh, okay. It's not my day.
Don't worry.
Okay. So let's go to treatment then. After checking the history, the examination, everything supplied in the child. So what treatment do we need? Simple febrile convulsion or seizure, as we said, they return to baseline very fast, within 5 or 10 minutes. We don't need to use any medication like lorazepam, as we said, which is a benzodiazepine. It's not warranted. Sometimes parents ask, do we need to, on this chart, do we need any medication at home? Usually we tell them that we don't need, because we give them very good education about the condition, what to do if it happened at home, how do they actually deal with the child. We tell them that they should not panic. When it happens, it's going to happen because the temperature is the implication here. So they have to give something to lower the temperature. Sponging is also warranted, and they have to keep the child in a right lateral position, away from sharp edge, so he doesn't harm himself. And the important thing, they should not put anything in the mouth, of course, of the child until it goes away. If it remains more than 5 minutes, then they have to come to the emergency room. Antibiotics and fluids, okay. Fever should be treated. That's after, of course, the convulsion subsides. So hydration is important. We don't give antibiotics in this condition unless that we're sure 100% that it's a bacterial infection at the time of diagnosis. So antibiotics in febrile seizure and recurrence in children, it's a symptomatic review that the conclusion review provides very limited support of use of antibiotics in preventing febrile seizure. So some parents say, what does that mean? Some parents ask, do we need to give, when the patient have fever, paracetamol or antibiotic, ibuprofen, for instance, for regularly every 4 hours or every 6 hours to prevent the convulsion? No, that's not right. Once a convulsion, because it's a neurological thing. Once the cascade goes up, the convulsion will happen. So we usually tell them not to give it regularly. Just where they have to check the temperature. It's high, you give the paracetamol. So these are the references I go into. And thank you so much. I'm sorry for these frequent glitches today. I'm not sure what happened, but so sorry for that. I hope you enjoyed it. Thank you.
Thank you very much, Doctora. These things happen. It's technology. We get so used to the technology to make our lives easier. Anyone of the audience does have a question? No questions from the audience side? In that case, we would like to say thank you very much, Dr. Arasha, for your session here today. Again, you can hear it's a clinical subject expertise that is speaking here, and our parents can be rest assured to have such expertise at your facility. Thank you very much for your time here today.
Thank you so much. Thank you.
Next up, we have, again, please forgive me. Our next speaker is Ms. Narito from Trinity University of Asia, United Arab Emirates. And she will be presenting on leadership style, management practices, and their effects on nursing performance. That is a mouthful. Could we please join me in welcoming Ms. Narito for her presentation here this afternoon. Thank you very much.
Hello, good afternoon, everyone. Can you see my video, my photo?
Yes, thank you.
Hi, everyone. I am Marie Merlin Baroga Narito. I am a home care nurse for a decade. So I'd like to thank you for inviting me to be one of the speakers here in a conference, and I sincerely appreciate the opportunity. So before I present my work, so let me recap home care here in the UAE. I've been here in the UAE since 2013, and my first work is already a home care nurse. So home care in the UAE has grown into a key patient-centered service, delivering high-quality clinic care directly at home. We are managing patients at home, patients' home. So it provides skill nursing, chronic disease management, rehabilitation, post-hospital support, mother and newborn care, elderly, and mental health assistance, medication supervision, and help with daily living. Delivered by licensed professional like me, within coordinated healthcare networks such as physicians, physiotherapists, dietitians, and also coordinated with our the government whose patient hospital affiliated like SEHA or Mediclinic or NMC or Cleveland Hospital. So home care enhances comfort, safety, and family involvement. With options from scheduled visit to 24/7 or live-in care, it supports older adults, people with disabilities, and recovering patients in maintaining independence, dignity, and better quality of life. Why I choose I upgrade myself because, as I told you earlier, I've been in a home care in more than a decade, and I see a big concern, like most of the health home care nurse leaders, like home health care managers, mostly don't have the master's degree. So on my side, I want to improve myself also. I want to up level myself into a management and a leadership level. So can I turn off my video and I will present my work?
Yes, please go ahead.
Thank you. Can you see it?
Not yet.
Sorry. Wait, I will just share first. I'm sorry. It's okay now, ma'am.
Yes. Excuse me, yes.
Wait.
Marie?
Yes?
Yes, you may proceed. We can see your screen.
Why I cannot? Okay. So my topic is leadership style, management practices, and its effect on nursing performance from selected home care. So my advisor is Dr. Walahati Maxima Floranda in Trinity University of Asia. The overview of my research is first is introduction, statement of the problem, theoretical framework, conceptual framework, methodology, and summarized data analysis on statement of the problem. I have 6. So that is the leadership style, the management practices, self-assessed nursing performance, and the leadership style and self-assessed nursing performance, the significant relationship in the management practice and self-assessed nursing performance, and the action plan. The gaps presented, the recommendation, and references. First, the introduction. So we all know that nurses are widely recognized as the backbone of the healthcare delivery. Our impact on the patient outcome remains unexplored in certain clinical contexts, highlighting critical COP-IM study aims to address. So as a home care nurse, so This is the gap that I see. And also, in the leaders and employers, they are being guided by the rules through navigation of their challenge. Good management behavior could enhance nurse morale and satisfaction. Conversely, poor management could decrease motivational, leading to a lower quality of patient care. My purpose of the study is to conduct a review of examining and evaluating the leadership style, management practices, and its effect on nursing performance from selected home healthcare setting. So I have 6 statement of the problem. On the leadership style, I have 4 domains, which is the telling style, selling style, participating style, and delegating style. As we know, in telling style, there's a type of leadership is best used when employees need clear, structured guidance to complete a task. On selling style, encourage employees to think critically, problem solve, and take more ownership of their work. On the participating style, requires a hands-on approach that fosters teamwork and engagement. And delegating style is about empowering the team for growth. So on the statement of number 2, SOP2, what is the management practice of the nurse managers as assessed by the nurse respondent in the following domains? I have 4 domains, which is the planning, organizing, directing, and controlling. And as we know, planning, setting goals, and determining the best course of action, and organizing, arranging resources and tasks to implement it, and directing, leading and motivating people to work effectively, which is the nurses, and controlling, monitoring performance, and making adjustment to stay on track. And the SOP3 is what is the self-assessed nursing performance of the nurse responded. And 4 is there significant difference in assessed leadership style of the nurse managers to the nurse self-assessed performance. And the SOP5 is there significant relationship in the assessed management practices of the nurse managers to the nurse self-assessed performance. And last will be the action plan would have proposed to enhance leadership and management practices. And my hypothesis is there are 2. There was no significant difference in leadership style and nurse self-assessed performance, and there was no significant relationship management practices and nurse self-assessed performance. On the theoretical framework, I only got the main, which is according to Pat goal theory developed by Robert House, leaders must inspire followers in order to effectively influence the achievement of organization objective. This one, in summary, this is the motivation. According to the Oroku 2022, the Pat goal theory asserts that effective leaders adopt their style directive, supportive, participative, or achievement-oriented to align with followers' needs and situational factors, enhancing motivation and ensuring goal achievement. In summary, this is the alignment. And contingency approach by Fedler's 1967, this is the contingency theory. So emphasizes the effective leadership depends on aligning the leader's behavior shaped by personality and situational demands with environmental factors like task structure, leader-member relations, and positive power to influence the outcome. This is the adaptability. And transformational leadership theory by Burns by 1978. So it centers on recognition followers' capabilities and fostering mutual moral and motivation growth to empower collaborative pursuit of shared vision. This is all for the empowerment. For the conceptual framework, so as you see, on the first back, there's the leadership, which composed of the 4 domains, and the management practices have also the 4 domains. And my dependent variable is the self-assessed nursing for performance. The arrow is straight because it will connect, the relationship between them. And for the arrow of this management and practices self-assessed nursing performance, there's a reciprocal relationship of them. And the arrow down would be the action plan to enhance leadership and management practices. For my research methodology, descriptive correlational only describe the relationship between the variables, the independent and the dependent variables. Actually, my independent variables will be the leadership style and management practices. I have 2. And the dependent variables would be the nurses self performance. My location, research location will be the home healthcare here in UAE. My target, the head nurses, nurse leaders, composed of head nurses and health managers. But the respondent will be the respondent will be the home healthcare nurses. And for person sampling, I choose this one because I have the inclusion criteria and the exclusion criteria. The inclusion criteria, nurses who are working at Department of Health accredited home healthcare setting that caters diverse patients like children, adults, geriatric, and maternity. And they must be nurses who are located and working in setup in Abu Dhabi only, and must be 21 to 50 years old, and must be willing to voluntarily participate and provide informed consent. My exclusion criteria will be nurses who are working outside the healthcare setting, like example, rehabilitation, OPD, ambulatory, medical center. And also under department accredited, which is not from the department of the health. It's not what do you call this one, those home care that are not accredited, what I mean. So for the leadership management and job performance, I use the adapted tools. Actually, I have 3 tools, which is from Ken Blancard, that is usually worldwide, or regarding the leadership management. The second one is the management practices with John Henry Fayul, and the third one is for the nurse assess performance. So it is validated by 3, one from the home care with 20 years experience, and one in the hospital with 15 years of experience. They have already the master's degree and doctorate degree for this one, the second validators, and the third validators have a 15 years of experience in a clinical practice. For the summary of data, so these are the analysis that I use in SOP1. It would be descriptive statistic, frequency, and percentage. In SPO2, I will use weighted mean. SPO3, weighted mean. SPO4, use of the ANOVA. And SPO5, person's partial correlation. And SPO6, a formulation of the action plan. So for the result of the SPO1, these are already. So as you see, participating, the total frequency is much higher. So in the interpretation of this one, participating leadership style is the most frequently identified style among nurse managers, which have 28.6%. So characterized by shared decision making, collaborative, problem solving, and mutual trust. The second one is the telling, which composed of 27.8%, suggested that the nurse managers still use directive approaches in situation requiring clear instruction and close supervision. Meanwhile, the selling style with 27% commonly observed, highlighting managers' effort to motivate and explain decision to nurses. And lastly, delegating style ranked last with 16.6%, indicating that nurse managers seldom provide full autonomy or independent task management without close supervision. On the summary of the management practices on my SPO2, as you will see, the result is always, and I have only the staffing with often. So the interpretation of this one indicated for the result of 4.03 always indicated that the nurse managers consistently demonstrated effective management practices among domains. For the planning, have the result of 4.6, so highest rating, shows the managers regularly engage in goal setting, policy development, and data-driven decisions. And in directing, with the result of 4.04, highly rated, implying consistent supervision, guidance, and clarity in work expectation. And for the organizing and controlling, rated always also, reflecting well-managed workloads, resource allocation, and mentoring of unit, self-assessed performance. And last, the staffing received the lowest but still high in rating, suggesting areas of improvement in professional development and motivation strategies. For my SOP3, so in job performance, they reported being punctual, able to meet deadlines, manage priorities, propose solution, and demonstrated professional interaction with colleague, patient, and other departments. So assess themselves as positive, and rating did not reach excellent level, suggesting potential for further development in leadership, communication, and problem-solving abilities. So the result demonstrated a competent nursing workforce with strong foundation performance skills. In the SPO4, um, the interpretation of this one, the phi value of 0.039 was less than the 0.5 significance level. Therefore, my hypothesis was rejected. So this indicated that was statistically significant difference between the leadership style of the nurse managers and the self-assessed nursing performance of the nurses. To identify which leadership style was associated with higher self-assessed nursing performance of nurses, the MENS score of the group were compared. And overall, only the selling leadership style was significantly related to self-assessed nursing performance, and the difference was negative. Other leadership style did not show significant association with performance in this study. On my SOP5, so this is the result. So there was a significant positive correlation in the controlling practice and self-assessed nursing performance, with the result of coefficient of 0.0834 with p-value of less than 0.1, indicating that keeping an eye on assessing and adjusting performance was essential to upholding high standard. And planning, organizing, staffing, directing, controlling, the five management practices were all substantially and favorably correlated with the self-assessed nursing performance overall, so indicating the significance enhancing work outcomes. For the action plan, I already forwarded this one, some of the home care here. So they already adopted, and also there is already as according to them, because I do a feedback, according to them, there's a positive result on following this action plan. So my objective number one is strengthen participatory leadership practices. So under the column, you will see strategies, persons involved, time frames, success indicators, and evaluation method. For the number one, conduct regular staff meeting, encourage shared decision making, implement feedback mechanism. Person involved were with the nurse leaders, head nurses, supervisors, managers in home healthcare setting. Time frame is 3 months. Success indicators, increased staff involvement and collaboration. And evaluation method should be staff surveys and meeting minutes. For the action plan 2, balance directive under telling style approaches. So provide instruction in high-risk situation, train nurse leaders on situation leaders, and reduce over-reliance on directive methods. Persons involved, same. Time frame will be 4 months, and the success indicators improve quality in task execution, reduce dependency, and the evaluation must be task audits, supervisor reports. And the action plan 3, enhance selling leadership style for motivation, which organize workshop on pervasive communication, link organization, goals to staff contribution, and recognize achievements. So person involved, same, plus the administrative staff. And time frame is 5 months, and success indicators, higher staff motivation and understanding of the decision. Evaluation method, it should must be self-interviews and recognition and records. In action 4, Plan 4, expand delegating practices, assign independently tasks to competent nurses, provide autonomy with clear guidelines and monitor outcomes. Person involved, same. Time frame, it will be 6 months. The indicators will be increased accountability and independence among nurses. And evaluation method, task completion, reports, performance, and outs. And 5, actually I have 8 action plan. So the number 5 is improving staffing practices, develop professional development programs, so strengthen retention strategies and align staffing with workload demands. So for the persons involved, same with administrative staff. Time frame will be 4 months, and the indicators, efficient operations and well-structured workloads. And last, task record and policy review. And the 6 is enhanced planning and organizing practices. So implement data-driven making, align unit goals with organization policies, and optimize resource allocation. Same persons involved. Time frame is 4 months. The indicators, efficient operational and well-structured workloads, and evaluation, task records, and policy reviews. And the 7 is strengthening directing and controlling practices, which provide consistent supervision, monitor performance, and standard and for standard through regular audits. Same person is involved. Time frame is 6 months. Indicator is timely task completion and adherence to standard, and evaluation is performance reports audits result. And last, evaluate self-assessed nursing performance. It will conduct leadership and communication and training, encouragement, teamwork, and provide opportunities for problem-solving exercise. The person involved is same and still ongoing this one. And improve self-assessed performance rating, and evaluation will be self-assessment performance appraisal. The gaps that I seen for the leadership practices revealed limited application of delegating style, with nurse leaders seldom granted autonomy. There are very restricted opportunities for independence and accountability among nurses. While selling style was commonly observed, with significant negative relationship with self-assessed nursing performance, had indicated a gap in how motivational communication was being applied, need for the refinement in the persuasive leadership approaches. In the management practices, consistently rated as always, yet staffing received the lowest score, suggests deficiencies in professional development, retention, and workload alignment that requires strategic improvement. On the self-assessed nursing performance, rated themselves as above average but not excellent, underscoring a gap in advanced competencies such as leadership, communication, problem solving, while reliance on self-assessment had introduced potential bias and limited objectivity. Statistically, the ANOVA result had confirmed the leadership style significantly influenced self-assessed nursing performance, but small effect had suggested that other unmeasured favors, such as institutional support, workload, intensity, and individual nurse characters also played a substantial role. And also, in correlation in the management practices and self-assessed nursing performance were strong, had remained non-casual, leaving a gap for longitudinal or experimental research for established direct effects. And finally, study was context specific to the home healthcare setting, limiting general CBT to hospitals or other clinical environments, and had lacked longitudinal data to capture changes over time. Emphasizing the need for balanced leadership approach, improving staffing strategies, objective self-assessed nursing performance measures, and expanded research design to strengthen nursing administration and workforce outcome. On the recommendations, I have actually 5 for the home healthcare nurses, healthcare nurse leaders, for the home healthcare setting on this one, and for the management in the home healthcare setting. So hoping this one will help on the home healthcare setting here in the UAE. And the last is that the future research. Actually, if I will be given again the opportunity, I'd on myself, I'd like to study on the doctoral degree and continue my work. For the references, I include all. I'm sorry, I put in the small size. And that's all my study. Thank you for listening.
Thank you very much, Marie, for your presentation and the time and the effort. It was actually a lot of information to take in. Thank you. It was very well put together. Is there anyone on the floor that would like to ask a question? Okay, so I will ask my question. In your opinion, in your years in healthcare, what have you seen are the most common styles of leadership or leadership styles that's being used? I'm not talking just about, what we see in theory, but what you have seen at the coalface, physically and in practice.
Thank you for the question, ma'am. On my 13 years in the home care setting, I've been on how many employers already, because I'm looking for a growth and development as a nurse as myself. So mostly I seen telling style. They're instructing what to do. They're instructing what to do, what you will do. Because mostly home healthcare setting is a business. So the result would be we nurses will do our work. So the result must be patient centered. We must follow the standard and everything. But the end of the line, it should be the business from our employers. Sorry for saying I'm saying what is the reality, but I'm hoping in the future that the employers would grant us or given us the total, what is that right term, the care and the acknowledgement from the nurses in every home care personnel in the UAE.
Thank you very much. I can see the passion coming through. Thank you so much, Marie.
Thank you so
Okay.
much.
We will move on to our very special guest this afternoon, who is Mr. Omar Ali. And it's my honor to introduce him and joining us from the United Kingdom, former NIS advisor and head of payers. And he will let me just say this, that he is highly respected and renowned professional in his field. And we are delighted to have him here today to present to us his topic, Can We Afford a Cure? Paying for Innovative New Medicines with Value-Based Contracting. Kindly welcome me in joining Mr. Omar Ali to the floor. Thank you so much.
Thank you very much, Yvette. Can everyone hear me? Can you give me a thumbs if it's all good?
Yes, you are audible.
Audible, fantastic. So I'm going to put my screen up here and just give me a thumb if you can see my screen okay. Perfect. So listen, it's really great to be online. It would have been better to be with you. I think I have been presenting for this brilliant conference company, UCG, in Dubai for a few years now. So it was very disappointing to not be able to come and share my expertise. But having said that, I think you will still enjoy this presentation. So this is really the area of innovative contracting. I'll explain what I mean by that. I will give a little bit of background in a small agenda. So I worked as a government payer. I've been a pharmacist by background, worked as a government payer in the healthcare system within the UK after 20 years hospital, then 10 years in the government. And then I started my PhD in this thing called innovative contracting or value-based agreements, which I will explain what I mean by that. I'm now also visiting lecturer in a number of universities around Europe and also some in the US. And I'm going to really give an introduction to what is this innovative contracting, what is it about, and why is it becoming very important. Now, this is really about medicines access, medicines pricing. And really at the moment, we're seeing a big global issue around the cost, not just of healthcare, yes, broadly healthcare, but certainly the cost of new innovative medicines. And there isn't a healthcare government in the globe who's struggling to try and balance the price of medicines and cure we all want to have and the negotiation with the terms with pharmaceutical manufacturers to get the right price and the right treatment. And some of it is because of the commercial model, some of it is because of the R&D cost, but we have reached a bit of a tipping point. And I'll give one example here. This was a gene therapy called Zolgensma, 8 million dirhams. And the question is, if this is the price of medicines, how are we going to move forward? Who can afford this medicine? Why is it priced like this? And how do we move along? Some of it is very political. So I can't answer that question today because if you ask the company, well, why is it 8 million dirham? They will give you many reasons why this is the right price, and they will say it's good value for money. Many governments around the world are saying, well, it's the wrong price, and if it's not affordable, then it's not going to help anybody. And it becomes to a very philosophical question, and we can see in this news article, what is the price of a human life? This is no one wants to answer this because there is probably a public health policy price, but then there's that price when you're a member of the family has an illness, then you don't want to put a price on the human life. The argument is that it's priceless, that we spend whatever we want, however much. There should be no limit because, of course, we love them. But that doesn't account very well. So if you're paying for something, to say that the budget is unlimited and to say that I don't care what it costs because I love my mother, brother, daughter is not a financial accounting model. It is how we behave as human beings, but it's not going to work as a medicines policy. Now, if you're interested in this topic, if you have a Spotify or Apple Music, I do have a series and you can access this. It's called the Payer Exchange. And in the series, I'm interviewing different pharmacists working in government across the globe, Europe, Saudi, US, and asking UAE and asking how do we move forward in this subject. So if this subject interests you, you can look at the Spotify URL and you can listen maybe in the bedtime reading if you have difficult getting to sleep. So what are the geopolitical drivers? If you look at how medicines are valued, it's a very interesting question how it's valued. There are three drivers: cost effectiveness, affordability, uncertainty. Those are the three drivers. Wherever in the globe, this is my part of my PhD, I'm seeing this. What do I mean by cost effectiveness? Well, many markets now are saying you don't just pay the price of medicine, whatever the company asks. Nothing in life is like that. Everything in life is a negotiation. What they say is, well, the medicine has to work, it has to be safe, it has to have good quality of life data, and there is what we call reference pricing. In the same way, like if you go and buy a new car, maybe your BMW 3 Series is a bit more expensive than the 2 Series, and the BMW 4 Series is more expensive than 3 Series. There's like a reference pricing on how much is your drug worth? How did you arrive at the price? And this is becoming harder and harder as more and more countries are getting more cute with the health economic valuation and saying to companies, you can't just price it whatever you want because we are at the mercy of our taxpayers to fund this. The second one is affordability. What do I mean by that? Well, if you look around the globe, we've had in the interesting last 5 or 10 years many critical global elements that have brought about fiscal reduction. What do I mean by that? Well, we're post-COVID. I don't think we really ever recovered from COVID. We have truly now global conflict in multiple nations, as we can see now in the Middle East, we can see in Russia, Ukraine. These things generally create a fixed or shrinking fiscal economy. And by that, I mean many countries don't have extra fund and extra money to pay for expensive medicines. What they have is a shrinking economy. And so more and more medicines are more expensive at a time that the economy is trying to balance and governments are trying to save. And that makes quite a hostile environment for companies coming with expensive drugs. I was presenting in the US last month, and I want to share with you, I looked at the top 10 most expensive medicines in the world. This is the price now for the new gene therapies. This is my area expertise for rare disease, for cancer in dollars. And it's the cost to treat one patient for one infusion. You can see here the price is becoming quite outrageous. 1 million, 2 million, 3 million, 4 million, 5. The latest one was 4.25 million Libmeldi for MLD. This is for one injection. Who is going to afford this? Because if that's the cost to treat one patient, how am I going to afford to treat multiple patients? If you're a government, it's going to be very difficult. If you're private, well, you tell me who privately can pay for this. So it seems that with the new innovative medicines, the pricing is going to maybe break the bubble. And I put this slide up saying, will the bubble burst? These new gene therapies really are quite exciting. They may be like a cure because just imagine if you have, say, diabetes type 1 and you're injecting insulin 2 or 3 times a day. Imagine if you have a gene therapy that comes and you inject once today and you walk out cured, never needing insulin ever again. This is the concept of the gene therapies. That instead of taking a tablet every day, instead of taking injection every day, you have a gene therapy you take once and you're done. This is the rationale for the price being 1, 2, 3. You saw Zolgensma, 8 million dirham. The idea is you take one dose and maybe you're cured. And I say maybe because nobody knows. Because to know if the cure works, you'd need a trial that lasts 10 or 20 years. No one doing a trial for 10 or 20 years. Their usual clinical trial, maybe 3 years. So, of course, it becomes a question of risk. I don't know if it works. Uncertainty. And many of the diseases are rare, but if you collect all the rare diseases together, it's around 1 in 17 people. It's quite common. So if you're a government or a health insurer paying for these medicines, it's going to add up very quickly. The final one is uncertainty. And that is, with medicines, we always have uncertainty. We know that. If a doctor or a nurse or a pharmacist prescribe a medicine and maybe it works, maybe it doesn't, that is uncertainty. Now, if the medicine costs $100, $1,000, maybe even $5,000, if it works, good. If it works, okay, not great, let's try something else. But let me tell you something. If that medicine costs 8 million dirhams and it doesn't work, I have a big problem. I really do. Because that is not a risk anyone will take. If it costs $100 or $1,000, I'm happy to say, fine, it doesn't work. When it costs 8 million dirhams, I'm not going to say that. I'm probably going to say, I want my money back. Whew, that's a whole new thing. And this is what my PhD is about. How do you contract with medicines so that if it doesn't work, you get your money back? It's quite an intriguing concept, but in truth, it's not really that innovative, okay? If you buy an iPhone and it doesn't work, you can ask for your money back. If you buy a new car and it breaks down, you can get a warranty. Most things that you purchase in life, there is a guarantee. What's interesting is it's never applied to medicines. You buy medicine, you pay for it, whether it works or not. My PhD looks at flipping that story and saying, if it doesn't work, I don't want to pay. It is really quite intriguing. And what I will tell you is, whilst this concept is uncommon and a lot of the companies don't like it, It's happening. And it's happening because of the financial pressure, particularly at the high end of innovative medicine. Not your everyday blood pressure tablet, not your everyday asthma inhaler, at the high end. High cost gene therapy, CAR T, oncology, rare disease. I want to share with you a story. When I was a government payer, this was my introduction to innovative contracting, and it's just a very clever story. What was happening? I was in the government at the time, an organization called NICE. There was a big negotiation, and there was a product called Velcade. It was for multiple myeloma. It was a very high price. It was very innovative, no doubt about it. It's the first time we were using a monoclonal for traditional chemotherapy, and we all know in the room how chemotherapy can be effective, but it's harsh on the patient, no doubt. And at that time, the government was refusing to pay a premium price. And we were struggling with the negotiation. So the negotiation became what I'm going to say stalemate. What I mean by stalemate, there was argument about the patient population group. There was argument about how much discount we wanted. There was question about should you go back and do another trial or a study. And the stalemate meant nobody was moving forward. The government were not agreeing the price. The company was not agreeing the discount. I'm sure there must be times when you are in a shop or you're buying a car or you're buying a property or something at high cost and your negotiation will stall. Maybe you're negotiating your salary and sometimes both parties don't agree. The problem with this is there's a medicine for cancer that all of the patients want to have, but the negotiation has stalled. There's no good news for anybody. In this story, something happened which I'd never seen before and led to my love for this PhD. This stalemate situation where no party is moving in the negotiation, the company did something very clever. They said, I have a deal. What happens if you give us our high premium price, you give us a broad population, and we give you a guarantee? We'd never seen this in oncology before. The guarantee is like this. If after 4 treatment cycles, the patient's cancer is not cured, you get your money back. Wow, like that was quite a thing. It was at the beginnings of these kind of negotiations that I fell in love with value-based agreements, innovative contracting. It was my PhD. Fast forward now a number of years, and I'll take us to the US. Gene therapy, $3 million. Sickle cell anemia affects a lot of patients. And US government and health insurers have agreed a outcome-based contract which says if the patient have the gene therapy and within 3 years they come back to hospital with a flare, then with vaso-occlusive crisis, then the company will give the health insurer and the hospital the money back. So they're basically saying if it's not acting as it should, you'll get paid back. This is one in China. My PhD goes around the globe. China doesn't normally do these kind of contracts. They're quite difficult. They're not easy, but Pfizer did with Ibrance. And this was a PFS guarantee of 4 months. What happened was the clinical trial, as most clinical trials, they tell you in theory a drug works. It doesn't tell you in real life if a drug works because real life, as you will know, is very different to clinical trial. And what happened was the Pfizer said with this was a Meditrust private company as well as People Insurance Company Group of China, like a financial body, a 3-way agreement to say if the patient doesn't have at least 4 months progression free, you will get 1/3 of the price back of the medicine because we haven't fulfilled what we were hoping to fulfill. So, and I'm also working very closely. In fact, I do some work. There's a very good pharmacist there from King Faisal. If you go on my LinkedIn page, you'll see some work I've done with him. And KSA is currently implementing a lot of this value-based, and they're doing value-based contracts, value-based agreements, particularly at National Guard and King Faisal Hospital. And this aligns with the KSA's broader plans in Vision 2030 Health. The idea is you link reimbursement to the outcomes. This is about value for money. It's not saying, does the drug work? Maybe it does, maybe it doesn't. What it's saying is, if my iPhone doesn't work for me, give me a guarantee. Give me a guarantee, or I'm not going to buy it. I'm not going to buy it for me. I'm not going to buy it for my population. It's quite remarkable. If you look at the literature, there's different types of value-based. There's financial, there's outcome-based, where you measure the endpoints, or you measure the cure rate, or you measure a blood test. And there is some service-based where you measure some infrastructure. We can go into some of that. I've been following who is doing it. And what I would say is, look, most of the medicines do not need outcome-based. Most of the medicines that you and I deal with day to day is normal, functioning, acquiring, standard negotiation. These outcome-based is kind of for those few medicines, but it's increasing because the technology of the gene therapies is increasing and becoming more and more common. And so for the governments to pay these high costs, over $1 million plus, this kind of contracting is increasing. But what I would say, this is about value-based healthcare. It's a continuum. And let me give an example. In the UK, for so many years now, traditionally with medicine, we used to pay hospitals and doctors and nurses for the hours they work. Still true. And yesterday, the model, when I say yesterday, some years ago, the physician would say, look, I saw 20 patients, I did 10 x-ray, I did 20 blood tests, I did some manipulation, I did some radiotherapy. So pay me for, I'm going to say, activity. Healthcare would ask the question, what did you achieve? Not what did you do? How successful were you? Nobody knew. No one is monitoring. You just got paid for doing whether you did a good result or a bad result. Now, if you look in the UK, for example, we're not alone. We are doing value-based healthcare in contracts with organizations, and the physician's salary in primary care, for example, the government has taken half that money from activity and put it into performance-based. I'll give one example. Let's say you run a diabetic clinic with 100 patients. In the old model, you'll get paid for seeing 100 patients. In the new model, you get half your money for seeing them, and you get the remaining half only if their blood sugar is controlled. If the blood sugar is not controlled, you lose your income. This really is a performance base, is reimbursement on value, and it asks an interesting question. If your doctor is running a diabetic clinic and working very hard, but none of his patients have got a good glucose, what's going on? What's happening? What's he achieving? If he's not achieving anything, why am I paying him? Very good question, him or her. So it's a continuum. And we are seeing this movements to value-based healthcare, not just with medicines, but with healthcare organizations broadly. And it's catching on. And even in Dubai, we've seen the value-based healthcare model is moving across various diseases, just like we have been doing for at least 10 years. There are some medicines it's going to be very difficult to show the value. Sometimes the price of the medicine is whatever the company wants to make its profit. The world is moving away from that now. The world is moving to a model where they're not saying you can just price whatever you want. They're saying you need to price proportional to how much the medicine delivers to my population. Now, how we measure that, how we investigate that, very challenging. But this is the new mantra. And I use a simple model to explain. Here's a disease. On the left is disease progression, getting worse. On the right is time. So the patient is getting more and more symptoms. We give the treatment. What happens after the treatment? Any difference? Does it maybe slow down? Does it halt the disease? Is it disease reversing? Is it curing the disease? This is the model we are now using to negotiate the price of a medicine. And if the medicine costs $5 million, but it doesn't have evidence that it's going to cure or reverse, we're not paying now. That's what's happening. It's created many problems, but this is where we're going. And most medicines, when they come to market, they want good access, they want the best price, they want it immediately. Do you remember the Velcade story I told you, where we got stuck at the negotiation table? And the way in which we resolved the stalemate was the value-based agreement with the medicine. I've given a small little window of innovative contracting. I hope that the audience today has enjoyed it. And I do hopefully look forward to maybe coming and presenting in person in Dubai at the next event. Thank you very much for listening. And of course, I'm happy to take questions. Thank you.
Wow, that was something different and really enjoyable. Thank you so much for your time. It's an eye-opener. Definitely it is. And I'm quite sure somebody must have a question around the table for you. May I ask, is it already Dr. Omar Ali, or are we still getting there so that I can, approach you in your proper title?
Oh, yes, we're getting there. My first thesis paper was around how using, how when you pay for a house or a property, it's like a mortgage payment. Our first paper was you could pay for a drug that cost $8 million like you pay for a property. It is you put a deposit as a down payment, and you know how you pay a mortgage monthly payment for maybe 10 years,
Many
20
years.
years. For the medicine, what would happen is you put a down payment to acknowledge the cost of the medicine and the research, but then you pay a mortgage to payment every 3 or 4 months, dependent upon the blood test or some result. And now they're using this model in Europe for CAR T therapy for some of the blood cancers, where they will pay maybe either half or one-third of the price up front for like Kymriah. And what they do is at some point with the blood test, if the patient is still in remission, they make a mortgage payment and they keep paying. As soon as the patient has relapse, they stop paying for this patient. And what it means is that price of the drug is going to change for everybody. Does that make sense? So
Yeah.
if the price, like CAR T therapy, is 1 million or half a million, some patients will get the full price. Some patients maybe get half price. Some patients maybe get very little if it doesn't work. The reimbursement is all being linked if the medicine's effectiveness. This is what this is about. Does that make sense?
Absolutely. Well, I think there was a question that was pointed, I should ask you. It's how does it differ from traditional payment methods for medicines? I think you just explained that if I'm not
Yeah.
mistaken.
At the moment, if you pay for a medicine, you pay up front. Like you go to the pharmacy. How do you buy a medicine? They'll say it's 100 dirhams. You pay your 100 dirhams. Maybe it works, maybe it doesn't. Tough. Correct? Do you
Yeah,
think that if the pharmacy says, "Oh, this tablet will treat your headache," if it doesn't treat your headache, you think you can take it back? Get your money
no,
back? Nobody.
no,
Nobody will give you your money back. Correct?
correct.
This is changing that paradigm.
It's a huge shift. Thank you so much. I would love to see you in person when you come to Dubai and attend one of your conferences. Really a pleasure to
Yeah,
have had you here today.
I would love that as well. And thank you for having me. And yeah, maybe next time we'll meet in person.
Next time. Thank you so much, Mr. Omar Ali.
Okay.
So I think
Hello, everybody. Can you hear me? Can you hear me and can you see my screen now? Yvette? Hello?
no, I'm here. I'm here. I'm here. My
Hello.
apologies. Yes, you can hear.
Can you hear me now? Do you see me?
Yes.
Everything clear?
Yes, absolutely
Okay.
clear. Your slides is also clear.
So I can start my presentation, right?
Yes, I would just like to apologize. So we will break for lunch once Dr. Khan is finished. Thank you.
Thank you very much. So I would like to start my presentation with some kind of announcement. So I'm Dr. Orhan Gasimov. I come from Azerbaijan, from its capital, Baku city, and I am an orthodontist. So personally myself, I'm doing orthodontist since 2006, and it's been already 20 years, and that 3,000 cases already treated. So today I will be speaking about biomechanics and how it affects our everyday life within our patients. And it is very interesting. I picked very complicated case, and I'm sorry if someone will understand this, that it's very complicated, but it's very complicated, very interesting. So this is the Baku city I come from. It's the Bay, and this is the university where I do teach since 2016 as an associate professor on the Department of Dentistry, the Department of Orthodontics. And this is my lovely team who helps me to achieve everyday goals. So let's start with the patient right away. So this is the patient who is a referred patient from another clinic. So she had braces before, and she was very disappointed within her treatment. Why? Because of this canine. If you can see this canine and this lateral incisor, they're stick to on top of each other. So in this case, this is very complicated because this canine is out of the bone. So in this case, what we have to do and what I have to plan. So again, this is her intraoral pictures and extraoral pictures and her profile smile and her X-ray. Of course, we are doing X-ray. We see here, at least without any kind of measurements, we did a lot of measurements on her, but I have no time to speak about all of them. So she's like quite good, skeletal and dental balanced, but she has the main issue with that canine, which is out of the bone. So if you would like to see in a panoramic X-ray, the tooth number 12, which is the upper lateral incisor, and 13, which is upper canine, right canine, they're oriented this way in the bone. So we have to distinguish them. We have to open their roots and to be able to avoid any kind of root damage. So in this case, we did CBCT, cone beam computer tomography, and here we see the level of the bone around the root. And here we can see on this picture, I can see that at this level of the bone is already finished. So let's measure this distance. After measuring this distance from the apex of the root until the losing bone area, we can measure and understand that this number is, let's say, 7.6 millimeters. So out of that range, our root is outside of the bone. So we have no chance of rotating that tooth or moving that tooth until we put that tooth inside the bone again. So let's see what we will be doing. First of all, again, we're starting with these pictures, and I would like to see this kind of teeth and understand their biomechanics. So they are oriented in the bone like this. And if I will move my tooth this way, so back, my root will be damaged with the canine root. So this is the wrong movement. So what I basically have to do in here, let's return back and see it again. This is the center of resistance of the tooth, and this is the center of rotation. So center of rotation is blue dot. And that is the point around which my tooth is rotating. So I have to pick my center of rotation. Again, if I move root back, I have damage on my crown level. So again, this movement is wrong. So what I have to do basically, again, I have to move my tooth back with the center of rotation where? Let's ask that question. So if my center of rotation will be on top of the apex, my tooth will move this way. Is that correct? Not really. But if I move my center of rotation to the edge of the tooth, so my tooth and the root will move inside. That's the desired movement. That's what I want to do. This is the right movement. So how do we achieve this? This is not so easy. So let's see how can we create treatment plan to be able to make this happen. So we have the force which will move that tooth inside. We create that force first, and that force in the biomechanics we know is divided by two elements. First, the same force from the center of resistance, and the second is the moment. In this case, this is very positive moment because positive moment is clockwise moment. But in this case, again, to be able to move center of rotation to the edge of the tooth, we have to create some big negative moment somehow. This kind of moment. So this way, our point of rotation will be on the edge of the tooth, and we will have our root moving inside, and the tooth, whole entire tooth will be moving inside. And these two moments will be negating each other, and at the end we will have this balance, this force and this moment. So I would like this kind of movement and this kind of rotation. Again, now let's see video. So we can understand that this is our bracket. Okay, so with this starting. Yes, so our bracket is oriented as the angulation of the tooth. So we can see that the slot of the bracket oriented down. This means that the torque, so front and back axial inclination of the tooth oriented upwards. So outside, we call it positive torque. So we have different things to do. So I would like to think if I would rebond my bracket from inside of the tooth, what will happen? Because I have no chance of bonding this bracket on the vestibular side of the tooth. So I'm moving it inside, I'm moving it, turning it 90 degrees and again 90 degrees. And what happened now? Angulation has changed, as you can see. So now my root will move to the side which I really need. And the torque, what happens with the torque? Let's see. I have to move that bracket. I have to incline that bracket this way to be able to put it on top of the lingual side of the tooth. So this way, what will happen to the torque and what will happen to the angulation of the tooth? This is very important. So my root will be going to the other side. So it will not interfere with the root of the canine. This is the number one thing I need. So angulation, which is mesiodistal, the right and left in this case, movement is correct. Now, from lateral view, from the side view, we can see that the torque is oriented down. And let's see, if I put my metal wire inside of that slot, what will happen to the tooth in this very case? This is the wire, and this is the Pitts bracket, which slot is 21 by 21, 0.021 inches. So the wire is 0.016 by 0.016. So it's square. And we put that square wire inside the slot. And what will happen? What's going to happen? We have to understand that in this case, our tooth will move. Let's see. So I have to put my wire inside of the bracket this way. So it doesn't come this way, right? So we have to move it and we have to turn it a little bit. Just check it right now in the video and put it inside. So wire will try to move back. Therefore, it will move the tip of the tooth inside. We call it negative torque, but in this case, positive moment. But I didn't need it. I needed, if you remember, I needed very big negative moment on the tooth. So this orientation of the bracket in terms of torque is wrong. So what we have to do? This is very, very, very important question in this case. Let's get system back and add canine to the system. Let's do it quickly. I'm just increasing the speed of the video. This is the canine, and I try to put it exactly how we can see it inside the mouth of the patient. So well done, canine is on their place. And now we're trying to do the same stuff. So we're trying to see what will happen if we move that wire inside the slot. Okay, let's move it inside. And let's move and see what will happen. In this case, the bracket will move positively and the tooth will move positively, resulting root movement, which is not needed at all. Again, we had to create negative, very big negative moment on that tooth because we are moving it's inside, and we have to create that negative moment, which will help to move that root inside. So our point of rotation will be on the edge of the tooth. This is very important. So what we have to do, how do we have to think about this? So in this case, I'm thinking, let me just flip my bracket. And if I will flip my bracket, what will happen? Okay, let's flip it. Let's see. So before flipping, I'm thinking I have to bond it somehow this way under the angle because, and also, yes, I have to flip because when I flip my bracket, the torque orientation is changing. So after flipping, what will happen? Let's see. And as we can see here, it's not enough. It's not enough at all. It becomes like something like the zero. So it will move, it will not create any kind of movement because it's almost horizontal. But we needed very big negative moment from this point of view. So what I do, I'm just making a pad from the composite and bonding it at top of the lingual side of the tooth. So this pad, this way, if I bond it this way, I add some composite and put my bracket on. So how do you think? Did the position of the torque, I mean of the slot of this bracket, changed significantly or not? For me, I just started this way. For me, it's very less. So I have to increase my pad. Now, if I have this big pad, so angle is completely different. And you can see in this case, if I will put my wire from inside, what will happen? It will move my teeth, it will move my tooth with the root oriented inside. Again, so we take our wire and put it inside the slot. What happens? It just, now it will, and as you can see, we oriented it this way now. And then when the wire wants to get its memory back, our tooth and the whole system will move counterclockwise. That's the moment I needed before. So let's go to the case and see what happens. So from the start, I created this kind of system. I just bonded my brackets, some buttons, just to be able to make some space and put some separation elastic to be able to just to make some space, because my wire later on was designed this way. And I put TPA, which is transpalatal arch, just to be able to make some bigger anchorage in this case. So I use my 16 by 16 stainless steel wire and I put it inside. And in this case, I want you to see what happens. So this is the first pad. The pads of the bracket and of the vestibular side are almost parallel. So that's why I had to make band, which we call third order band, so on the wire, which is not really comfortable for the patient and for the doctor. It's very hard to make this small bending in this very, very, let's say, small area. So this wire is 16 by 16 stainless steel. And later on, I had to change my pad. And as you can see, this one is the increased one. And here, when we have the angle, the correct angle now we don't need to make any kind of refinements on the wire. And we just put bracket on, and we just put wire on, in. And when we put our wire in, what will happen? Now, what I want to do, from this point of view, I want to move my tooth inside, and I want this, I'm speaking about lateral incisor, because later on, we try to put our canine inside the dentition, inside the bone. So first of all, I have to make sure that my root of my lateral incisor is not interfering with the canine. This way, the next appointment, I'm just activating the wire, as what you can see here. I'm just making some first order bends, which we call like inset here. So we keep activating the wire with the same moment. And we keep it activating, and later on, we just activated it, as you can see here, with the elastics, with the elastic ligatures, and we still activating it later inside. So let's see what happens. The tooth moved inside, as you can see in the bone. Now our canine, because of the PDL, periodontal ligament, is pulled right behind the tooth, pulled back. So we try to put our canine inside. Now let's see what happened to the root of that canine. So this is second CBCT. And when on this second CBCT, we are checking the level of the bone. As you can see, this is the apex level. And in this view, we can see that there is still bone, and there is still bone, and here it stopped. So the whole length of the root now is in the bone, is the alveolar bone. So it is 15.7 millimeters. As you can remember, we started with 7.6. This is the twice as much, even more than twice as much as we were able to manage to put that canine inside. And if we want to make some comparison, you can remember the first one, which is on the upper left corner of the screen, and second CBCT, like several months later on, after all our biomechanical application. And we can see that the bony level of the first CBCT on the top left of the screen is, okay, let's see the number. It was, if I'm not mistaken, 7.6. Yes, 7.6 millimeter. And now it's 15.7. So it's more than 2 times bigger. Technology. So now what we are doing, and now we have time, we have like ability to be able to rotate that canine. And we keep making our treatment, we keep continuing our treatment because my root is inside the bone. I'm not scared anymore of moving that tooth. So we keep rotating that tooth, as you can see, at the next appointment and next appointment. So we use some power chains from one side, from another. We're just rotating it like mesial out. And we still keep rotating it because we create correct biomechanics. I know that roots of the teeth, they're not interfering. So I'm doing this freely. And we can continue. We still continue. And you can see the progress. Next appointment and next, we always keep picturing our patients just to be able to understand what we are doing. Next, and next. So canine is on its place now. Now we are starting to move lateral incisor back into the dentition. And the most complicated thing here is because we don't have like a very good point of application on the lateral incisor, so its surface is not very big. We gain some proclination while moving forward. So proclination is like something like this. So after that, we have to just, as you can see, we made some lasering here, put the bracket on and use 2 wires. So we use 2 wires just to be able to prevent that proclination, which we really don't need and which we really don't want. And we're moving it forward, and now tooth is on its own place. Now we are just trying to get rid of that proclination. We have several methods of that, using several Goodman springs, torques in the wire built in, or this type of idea. So while I'm having transpalatal arch here, I'm just using power chain from inside just to be able to rotate that tooth inside. So the patient is still on the treatment, but it is so interesting it was so interesting for biomechanical point of view, from biomechanical point of view. So I wanted to share it with you. So the patient now is started from this referral position, as you can remember, and now she is at this stage. So we have to just finish retroclining her lateral incisor and correct all the torques and put her smile into the position, create some smile arc and her height of the smile, and finish the case off. So the easiest part left. So now I would like to thank everybody for your kind attention, and I would like to thank the executive committee of the conference for letting me lecturing in your wonderful presentation in Dubai. Thank you very much.
Thank you very much, Doctor. I think that concludes our session for this morning. If anybody has a question for Doctor, please go ahead and pose your question. It doesn't seem anyone is.
As I said, it's a little bit complicated for non-orthodontists for all this biomechanical stuff, but it's very interesting. That's why I share.
Okay, what happened to my video?
Your video is blurred a little bit.
Yeah, I don't know. It wasn't like that for the whole morning.
Now it's gone. Now it's okay.
Yeah, I wanted to blur my background. I don't know. Anyway, we're gonna have a 45-minute lunch break. I don't know. Now I am having the technical issues. So we will have a lunch break for 45 minutes, and then I think we will convene after 45 minutes, which makes that 2:15 in UAE time. And hopefully then I'll be able to sort out my video. I think the video is now tired like me. Thank you so much. I think we can all enjoy our break now, our much reserved lunch break. See you later after the break.